Wait.
Good afternoon, distinguished faculties, organizing team, and delegates. It's my proud privilege to welcome you in the much awaited update on acute kidney injury. The purpose of this 2 days conference is to discuss current, important, and relevant topics associated with acute kidney injury. Astoma Sadgamen, Tamsoma Jyotirgamen. Let me move from untruth to truth and from darkness of ignorance to the light of knowledge. To re-emphasize our intent of this aspect, I would like to invite Padam Shri Awardee, PC Roy Awardee, Professor A.K. Bhalla, Organizing Chairman, President-elect Indian Society of Nephrology, to deliver welcome address.
Thank you, Ramandeep. Good afternoon, everyone. Warm greetings from New Delhi. It is my proud privilege to welcome you all to this ATI Update 2021, being organized by Department of Nephrology, Sir Gangaram Hospital, as part of biannual event, this being the third one, being organized on a virtual platform for 2 days. I welcome all the international as well as national faculty and all the participants. I'm sure we will all enrich ourselves with the vast experience and of esteemed and learned faculty. As is customary to start any event, we remember divine powers and seek their blessings. As light symbolizes brightness and prosperity and gives a lot of positivity, with this noble thought, let's start with lighting the lamp in front of Goddess Saraswati, a symbol of knowledge. May the divine power bless us all. Can we have the lamp lighting, please?
Shubham kurutvam kalyanam arogyam dhanasampadah. Shubham kurutvam kalyanam arogyam dhanasampadah. Shatru buddhi vinashaya deepajyotir namostute. Deepajyotir namostute. Deepajyotir parabrahma. Deepajyotir janardanah. Deepajyotir parabrahma. Deepajyotir janardanah. Deepo hartu me papam. Sandhya deepa namostute.
Yes, Ramandeep.
Yes, sir.
Now, may I invite Dr. Vinant Bhargav, the organizing secretary, to tell us about this update.
Thank you, Dr. Bhalla, sir. First of all, I'd like to thank my seniors. I have been blessed to have seniors who have given me the opportunity to conceive this program, which is titled Acute Kidney Injury and Update for 2021. Let me tell you something about the programs that we do from Sir Gangaram Hospital. This is a biannual update, which is done every 6 monthly. We have done 2 such updates in the past, which have had welcomed a lot of accolades from all over the world. This update was planned earlier in the month of May, in the first week. And unfortunately, as we all understand, COVID is what decides our fates nowadays. So we had to cancel when we had an exodus of COVID-19 in New Delhi in the first week of May. And then we replanned this conference again this weekend. And we also planned to have a hybrid conference. And unfortunately, because of government regulations, we were not allowed to do a live presentation. So to go further with the program, let me just tell you that acute kidney injury in the present day scenario is one of the most important modalities, because identifying such a disease can prevent chronic kidney disease, which itself is responsible for a very high morbidity and is a huge burden on the economics of the society. So over the next 2 days, we will take you through several topics by first introducing acute kidney injury, talking to you about preventing acute kidney injury in special settings, especially in patients with chemotherapy, immunotherapy, as well as patients with cardiorenal syndrome. We will further take you down to special populations such as pediatrics, elderly, as well as obstetrics, and discuss various aspects of acute kidney injury. On day 2, we are going to take you into a plenary session on the use of CRRT and its use in the current day literature on renal survival. Furthermore, we will be discussing with you about the crisis and follow-up of acute kidney injury, which in turn is responsible for a huge burden in the economics of a country. Without discussing the role of peritoneal dialysis in AKI, we thought that this update would be not sufficient. We will also be highlighting on the long-term outcomes of acute kidney injury, latest trials in acute kidney injury, and in the present day scenario, we couldn't have taken away COVID-19 and acute kidney injury. To sum it up, we will have two doyens who will be fighting amongst each other on the topic of use of biomarkers in predicting and in the long-term outcome of acute kidney injury. I'm sure that this program that we have designed from the entire department will keep you enthused through the next 2 days, and we hope that you learn from the experiences of the specialist speakers which are from all around the globe. We have 7 international faculties, we have more than 2,000 registered, and at the moment we have more than 500 participants live at the moment. I thank you all for your time and taking out your space to register for this event. And in the end, I would like to give my special thanks to Dr. Kenner Jhevari, without whom the conception of this program would be not possible. There will be a little bit of a word of caution here for the speakers. We will try to keep to the time of 15 minutes presentation, and we will request the chairpersons to take up the questions from the Q&A session at the end of each and every session. With this, I would like to thank you all for coming and joining us, and I would request Raman to take over now. Thank you.
Thank you, sir. As we know that excellence of knowledge is gained by continuation of learning. We are so fortunate to have a luminary who has been inspirational to so many people, who is an idol teacher for many exemplary teachers of nephrology, and whose guidance has created many brilliant clinicians. It's my profound privilege to invite Padam Shri Awardee, BC Roy Awardee, Professor D.S. Rana, our chief guest, to inaugurate this update.
Thank you, Ravandi. International faculty, National Faculty of Eminence, my colleagues from the Department of Nephrology, I welcome you all for this update being organized by Department of Nephrology of Sarganga Hospital under the chairmanship of Dr. A.K. Bhalla. The idea was conceived of this biannual topic-wise CME or update by Dr. Jant Bhargav and supported by the whole department. And I'm really very glad that this is going to be third successful update. This time we really hope that we will be meeting and not having this, or maybe having hybrid type of meeting. But unfortunately, due to this unprecedented surge of second wave of COVID in Delhi or in the whole country, we are still having this on the virtual platform. As told by Dr. Nath Bhargav, it really gives me pleasure that approximately 2,000 delegates from all over the world registered for this update. And at the moment also, 500 participants are participating. I have just seen that topics being covered over today evening and tomorrow morning. This will be really giving a brief view and exhaustive view of AKI, which still remains a burning issue in nephrology and from long-term pregnancy and short-term pregnancies. And the whole world is stressing the need on early diagnosis, early biomarker, so that we can prevent the progression of AKI to severe AKI and ultimately AKI to CKD. I am very sure that various talks by luminaries, I can see the very eminent person from the national side and international, those who are really leading the field, they're going to address various issues. It will be really pleasure to listen to you all. I wish you all success, and I wish success for this update. And once again, I thank and I congratulate the Department of Nephrology for organizing this event. This meeting is open. Thank you very much.
Thank you, sir.
Thank you so much, sir. Now, I would like to invite Professor Ashwini Gupta, co-organizing chairman, co-chairman, Department of Nephrology, Sir Gangaram Hospital, to deliver vote of thanks.
Good afternoon, everyone. On behalf of Department of Nephrology, Sir Gangaram Hospital and Renal Care Foundation, it's my pleasant duty to propose a vote of thanks on this inaugural ceremony of this biannual conclave. We are very thankful to our chief guest, Dr. D.S. Rana, Chairman Board of Management, Sir Gangaram Hospital, for inaugurating this conference, for his blessings, continuous guidance, and encouragement. We express our sincere gratitude to the international and national faculty for accepting our invitation. Special thanks to our speakers from abroad who have chosen to deliver their talks live even after a time difference of 10 to 12 hours. We thank all the delegates who are attending this conference and making it a mega event. And you can see the popularity, more than 2,000 delegates have enrolled. Our thanks to the partners from a pharmaceutical industry for their gracious support, especially Baxter, Panacea, Larenon, Elrich, Steadfast, Sun Pharma, Intas, Boehringer, and Rancord. Our thanks to the event management, meetings, and more for a smooth conduct of conference as always. Thank you very much and good evening to all.
Thank you, sir. Kidney health has been an important area of concern. There has been constant endeavor to study, research, improve, and innovate the available therapies to further enhance the kidney health scenario. Acute kidney injury and update is a step in the same direction and intend to discuss and dispense the advanced scientific information to the associated kidney health clinicians. Without much delaying further, I would like to initiate the proceeding of the scientific session, which is Introduction to AKI. It is my proud privilege to invite our chairpersons, Dr. Sanjeev Jasuja, Senior Consultant Nephrologist in the Prasta Apollo Hospital, New Delhi, Professor Sanjay Agarwal, Head of Department of Nephrology, Editor-in-Chief, Indian Journal of Nephrology, AIIMS, New Delhi, Professor H.S. Kohli, Head of Department of Nephrology, Postgraduate Institute of Medical Education and Research, Chandigarh. I would request Dr. Sanjeev Jasuja to kindly introduce Professor Edwin Fernando.
Yeah. So I again reiterate the fact that renal care year after year increase time, and I must compliment. With these words, I would like to invite Professor Edwin Fernando, Professor and the Head of the Department of Nephrology, Government Stanley Medical College, and he's the recipient of Award of Excellence from Government of Tamil Nadu for the year of 2018 and 19. Professor Okay, Fernando.
Yes. See my screen, sir?
Yes, sir, we can see your screen.
Good evening to all respected chairpersons, senior colleagues, and friends. I thank the Gangaram team for calling me to talk about staging of AKI. The field of critical care nephrology in AKI has been hampered by the long-standing lack of standardized system to diagnose and classify AKI. Over the years,
your slides are not visible, sir.
You have to stop, sir. First open the slide, then again share it. First stop.
Is it seen now, sir?
Yes, actually it is your computer screen only, and all the mails are there.
So you have to first stop share. And
I'll stop share, okay.
In background, open your slide in background, and then now share it again.
Okay. Can you see it now, sir?
So first open your PPT. First open your PPT and then share.
Yes.
Have you opened in desktop?
Yes, I opened the desktop.
Now share. Now do the share screen.
If you move the cursor down, sir, you'll see share screen.
Yes, yes. Can you see it now?
Yes, yes. Now you have started.
Now it's coming, sir.
Yes, yes, good.
Now you can
thank you,
maximize
sir.
it.
Yes.
Make it full screen now, full screen.
Yes, I made it, sir. Good evening. Sorry for the glitch. Is it audible now? Is it visible now?
Yes, yes.
The field of critical care nephrology and AKI has been hampered for long by the long-standing lack of a standardized system to diagnose and classify AKI. Over the years, a number of different definitions have been applied without well-defined terms. In 2004, 200 different definitions of AKI were provided by the involved clinicians. So these multiple definitions of AKI obviously led to a great disparity in the reported incidence of AKI, making it difficult, even impossible, to compare various published studies focusing on AKI. Why should we have a definition of AKI? A uniform definition is needed that can be applied in both clinical practice and research to enable recognition and treatment consistently across healthcare systems. Ideal definition of AKI should have a limited complexity. All of us know the New York Heart Association classification. It's very simple, and hence we all memorize it well. Correlation should exist between stages and outcome. High sensitivity and specificity should be there to detect AKI with a high diagnostic accuracy, and it should have low to moderate cost to operate the definition in real time. Towards this, a beginning was made in 2004 by Ronco's group, which was called the rifle classification, acronym being risk, injury, failure, loss, and ESRD. Here, the diagnosis and staging severity were based on two strategic parameters: a rise in serum creatinine from baseline and/or a decrease in urine output over a specified time period that was 7 days, and these were used as surrogates for GFR. So this was conceived to start a fundamental process for AKI definition and exact detection, at least for epidemiological purposes. So the rifle criteria allows identification of a significant proportion of AKI patients hospitalized in numerous settings, enables monitoring of AKI severity, and is a good predictor of patient outcome. However, it did not aim to trigger standardized therapeutic interventions. Neither did it aim to predict mortality or adverse outcomes. AKI is not a yes or no condition, but is characterized by progressive disease severity. More advanced the renal dysfunction is, worse the clinical picture, and therefore the outcomes would be. Down 2007, Dr. Mehta's group modified the rifle to call what is known as AKIN classification, acute kidney injury network. AKI severity was divided to 3 stages of escalating severity, 1, 2, and 3. The GFR criteria removed as markers of adult AKI. Only serum creatinine was used and a baseline was not required. The loss and ESRD of the rifle were eliminated since these were considered prognostic classes without classification purposes. The relevant difference between rifle and AKIN was the time frame criteria. While rifle uses a 7-day criteria, this is a 48-hour time frame within which a diagnosis of AKI must be made to fulfill the criteria. However, it should be remembered that the AKIN criteria also said that look at the clinical presentation, adequately fluid resuscitate the patient when applicable, and rule out obstruction as reversible causes of reduced urine output. Some facts about AKIN: modifications were based on cumulative evidence that even small increases in creatinine were associated with poor outcome, allowed the identification and stratification of AKI in a large proportion of hospitalized patients and independently associated with the outcome. AKIN could theoretically improve the rifle sensitivity and specificity, but did not exhibit a better prognostic acuity in terms of in-hospital mortality. In 2012, the KDIGO came out with their own definition of AKI, which was defined as increase in serum creatinine of 0.3 within 48 hours, increase in creatinine to more than 1.5 times baseline, known to have presumed occurred in the past 7 days, or a urine volume less than 0.5 ml per kg per 6 hours. The KDIGO criteria also allowed for correction of volume status and obstructive causes, though it was not specified. The modified criteria for stage 3 was a rise in creatinine to more than 4, or a rise of 0.3 milligram per deciliter from baseline with underlying CKD. This patient would otherwise be stage 1 in somebody without CKD, but with CKD, it go to stage 3 straight away. So the KDIGO criteria utilizes change in serum creatinine urine output, not changes in GFR for staging. The exception was 18 years, less than 18. Acute decrease in eGFR to less than 35 mils is a criteria for stage 3 AKI. So to sum it up, the rifle said increase in creatinine more than 1.5 or a GFR decrease more than 25%. AKIN said increase in creatinine more than 0.3 within 48 hours. The KDIGO said increase in creatinine by 0.3 in 48 hours or 1.5 times baseline, known or presumed to have occurred within the prior 7 days. Remember, the KDIGO combined the rifle and the AKIN. The strengths of the rifle were it was largely validated, determining incidence of AKI and prognostic stratification in several settings of hospitalized patients. It showed an independent and stepwise increase in mortality as AKI severity increased. It had good prognostic accuracy in terms of mortality, though it was not planned initially. Important tool in predicting patient outcome. Increased prognostic ability of those general scores usually employed in the ICU. However, there are limitations of this, and these limitations are a baseline serum creatinine is necessary, which is frequently unknown. Estimating baseline serum creatinine using MDRD equation, which is an equation for stable CKD, assuming a GFR of 75 mils. In CKD patients, a percent increase in serum creatinine is used to define AKI. So this generally occurs later. And defining AKI using only creatinine could diminish the sensitivity of AKI diagnosis in CKD patients. The prognostic capacity was definitely inferior to the Apache and the SAP scoring systems. And using serum creatinine had several other limitations, as all of us know. Acute rise in creatinine, the sarcopenia, drugs, enzymatic interference, etc. The other limitations of rifle was the decrease in urine output. The sensitivity and specificity of urine output significantly changed by use of diuretics is not addressed. You need to have a bladder catheter in place. The capacity of rifle using both criteria to predict mortality can be more stable than the ability of the classification employing only creatinine. The etiology of AKI and requirement of RRP is not considered. And however, it does not provide any information regarding origin of the renal lesion, subcellular, as opposed to biomarkers. So the major concern was the rifle criteria has been evaluated in only less than 2% of patients in prospective studies. The strengths of the Akin, you define only after adequate hydration status is achieved, adds important etiological information based on serum creatinine, not on GFR changes, and does not need baseline serum creatinine, but it requires at least 2 serum creatinine determinations within 48 hours. The limitations of the study does not allow identification of AKI when elevation of creatinine occurs after 48 hours. Stage 3 of Akin had to use all the 3 diagnostic criteria. Extreme variability in beginning and cessation of RRT, and extreme variability in the modality used among different physicians could limit the prognostic acuity, especially in stage 3. The strengths of the KDIGO was for patients reaching creatinine stage 3 by creatinine more than 4, rather than requiring an acute increase of 0.5 over an unspecified time period. And this brings definition and staging criteria to greater parity and simplifies the criteria. The limitation of KDIGO was AKI is diagnosed based on serum creatinine rise and or a fall in urine output, 2 markers that are not really renal specific and have own important limitations. Multiple studies have compared rifle, Akin, and KDIGO. Agreement between these classifications was reported only in 4 studies. In adults, generally good agreement between rifle and Akin. Only 1 study included KDIGO, and incidence of AKI was found to be identical to that of Akin. This is a prospective study of 1,000-odd patients, first 7 days after hospitalization with acute myocardial infarction. AKI defined by rifle was 14.8% and KDIGO 36%. Both rifle and KDIGO associated with increased 30-day and 1-year death rates. So patients diagnosed as not having AKI by rifle but AKI by KDIGO had increased risk of death. This is the Finland AKI study. Again, a large group of 2,000-odd patients, 17 Finnish ICUs, defined AKI first by Akin and then with the baseline creatinine, second with the KDIGO criteria. Similar incidence in AKI defined by Akin and KDIGO. This is a Chinese study, 30,000-odd patients. AKI defined and staged according to KDIGO, rifle, and Akin. The AKI incidence was highest with the KDIGO definition, followed by Akin and rifle, almost the same. So when you look at the mortality based on Akin and rifle, this is the nice publications. The ratio of odds ratio more than 1 with 95% confidence intervals, Akin was a better predictor compared to rifle. In multiple studies, KDIGO has been shown to be superior in compared to Akin as well as rifle. However, when you look at the surrogate measures of baseline serum creatinine, looking at the MDRD back equation, the nadir level in hospital and level at hospital admission, use of both the minimum baseline serum creatinine inflated the incidence of AKI by about half. The low specificities were low. The use of the admission serum creatinine significantly underestimated the frequency by almost about a third, yielding a low sensitivity. And the commonly used surrogate for baseline serum creatinine led to a bidirectional misclassification of incidence and prognosis of AKI in a hospital setting. So what are the challenges in applying these AKI diagnostic criteria? AKI is defined on an individual basis with respect to baseline serum creatinine. So choice of different baseline values can have significant effect on the sensitivity and specificity of the criteria. Baseline serum creatinine may not be. This can be on a case-to-case basis by the treating physician. And this has more relevance to database studies where you need to standardize the definitions. Interpreting AKI is more challenging in patients with CKD. Higher baseline serum creatinine values mean that small changes, rise of 0.3, might represent lab or biological variations rather than a true change in renal function. Conversely, a reduced renal reserve in individuals with CKD confers increased vulnerability. and a combination of threshold value and percentage changes in serum creatinine described mortality in those with a higher baseline serum creatinine. Alternate classification using absolute changes in creatinine, we don't have enough evidence for that. What are the limitations of these criteria? Major flaw criteria do not distinguish between different etiologies. Incorrect to treat AKI as a single disease, grouping together hemodynamic causes, etc. KDIGO guidelines specified that patients with AKI to be evaluated promptly to determine the cause, especially in patients who can have reversible causes of AKI. Another important issue is use of urine output as a sole criteria. KDIGO criteria define stages by change in either creatinine or urine output. Using urine output define a stage AKI is not based on any robust evidence, and there's conflicting literature if urine output determines the outcome. So the caveats in using urine output as a criteria: do not use a low urine output is an appropriate response of the kidney to reduce intravascular volume. So it could be just normal. And when the serum creatinine is still normal, it would seem inappropriate to diagnose them as having AKI. The use of a urine output criteria is important. Patients may not develop more severe AKI because they received appropriate care triggered by the onset of oliguria. So the urine output criteria would add predictive value to the AKI diagnosis. Again, limitations in the determination of baseline serum creatinine, impossible to calculate changes in serum creatinine. The Rifle criteria use the MDRD equation, which is actually not right in the sense that MDRD is used for stable CKD patients. The European Renal Best Practice Guidelines set the first documented creatinine. Initial creatinine may already be elevated above patients' usual baseline if the onset of AKI occurred prior to hospitalization, and creatinine production may be hampered in acute illness, and changes in volume of distribution of creatinine due to fluid overload may depress the serum creatinine and blunt the rise in creatinine during AKI. So many nephrologists feel that the average of creatinine measured 7 to 365 days prior to hospitalization best approximates the true baseline creatinine. This is a systematic review, 418 articles that looked at a definition of renal dysfunction multicenter RCTs in critically ill patients. 78% provided information on renal functions. Only 7 articles showed mean or median serum creatinine. The SOFA score was most commonly used definition of renal dysfunction. Rifle, Akin, and KDIGO criteria was used in only about 10% of the trials. In 13 trials, no renal dysfunction criteria were reported. So these systems, because of the inherent flaws, were infrequently used in many RCTs caused by on critically ill patients. And generally, the critical care people went by the SOFA score. So to conclude, no single definition for or classification of a complex disease such as AKI will be perfect. Essential components of a workable consensus definition would include: should clearly establish presence or absence of a disease, number 1. Must give an idea of the severity of the disease, number 2. Should correlate disease severity with outcome, number 3. And number 4, should be easy to understand and apply in a variety of clinical and research settings. However, as a wish list, we could have biomarkers which are included into the clinical bedside real-time GFR measurements and AKI alerts, which would make us recognize AKI much earlier. Thank you very much for the patient listening.
Thank you, Professor Fernando. Masterly presentation again. This has set the ball rolling for today's further discussion, and maybe will be carried forward tomorrow as well. Now, important thing is this question right now in Q&A so far, and since we have almost completed the time of 20 minutes allotted to us for this session, I would request if there is any question, Dr. Vinant, please forward to Dr. Fernando an email, and I think we can reply to directly the questioning.
Yes,
so Dr. So comes up, and with that we'll close this first session and we move to the next one. I'll pass on to the next chairperson or whoever has to take it. Thank you very much.
Thank you, sir. I would like to start our second topic, past, present, and future of AKI. For that, I would request Professor Sanjay Agarwal to kindly introduce Professor Patrick Murray.
So after the first talk of staging the ball rolling by defining the stage of acute kidney injury, I think there will not be a better topic on past, present and future of AKI. And to speak that, there is none other than the Professor Patrick Mare. He is full professor of clinical pharmacology, consultant nephrology and clinical pharmacologist in the School of Medicine, University College Dublin. And he has extensively published on biomarker, and we are going to listen him in last 5 decades what has happened and what he is expecting will change in future on AKI. Professor Murray, please.
Okay.
Yes, Professor Murray, you can share your slides.
I think it should be shared now.
Yeah, it is visible. You need to pull it. Thank you.
Thank you very much for the introduction, Professor Agarwal. And I would like to thank Vedant for his organization and the organizing committee for the invitation to speak to you today. Obviously, 15, 20 minutes is not time to cover everything that's happened and will happen in acute kidney injury, but I'll make some relevant comments. First, I want to bring you greetings from Dublin, from Ireland. This is by the sea. This is the university where I work. My house is down here, and that's where I am now, as we're still restricted a little bit. I want to declare a few disclosures, including some biomarker consulting and funding over the years. They're there for your records. And I was conscious of not making detailed comments about things that were covered by other speakers. And I'm glad I didn't make a lot of comments about, for instance, AKI staging, knowing that Dr. Fernando would do so. But just to cover the history, it's been well described that, you know, right back to the 40s when urea was measured, we've been defining and trying to deal with standardizing AKI. And in full disclosure, I've been a member of the rifle, akin, and then KDIGO groups, so I bear some responsibility for the staging and diagnostic criteria. So I'm glad Dr. Fernando didn't dismiss them as not functioning well. I was glad to hear that validation is accepted. And I think many of us have begun to use KDIGO criteria routinely as they integrate the best of the akin and the best of the rifle system. Although we do acknowledge that the urine output criteria are less validated. I do want to draw your attention to one publication which I did with a research fellow working with me last year, where we did propose perhaps a future modification of retrospective diagnosis of AKI that was present on admission, marked by decreases of 33%, 50%, or 66% creatinine, so that we capture the full range of AKI in clinical practice, in epidemiology, and in research. And we'll see how well accepted that proposal is. But we also endorsed the use of the AKD definition for renal dysfunction or damage lasting more than a week and less than 3 months. And I'll draw your attention to the fact that KDIGO had a conference I wasn't involved in last summer to try and integrate the diagnostic and staging criteria, or AKI and CKD. And their publication, I believe, is forthcoming to try and integrate the whole continuum of kidney dysfunction and damage, right from a short-term 2-day change right through to a 3 months or more with CKD by filling the gap with AKD. So keep an eye to that. As was mentioned, we've spent a lot of time looking for markers of kidney damage that would help better characterize and phenotype what is wrong with the kidney when the creatinine is going up, and then perhaps to tell us before the creatinine goes up, is there kidney damage which will lead to dysfunction if it's unchecked. And this meeting of the ADKI group we held in Dublin, I co-chaired it with Ravi Mehta, and we published the 2011 meeting in 2014 and came up with this 2x2 table which reflected the literature at the time, and I believe still reflects the literature, That is that in patients who have no kidney dysfunction, their creatinine and urine output are fine, who have no evidence of damage biomarker elevation, they've got no element of acute kidney injury. In those who have what we commonly call pre-renal, or more recently functional AKI, they have decreased GFR and or urine output, but no elevation of damage markers. And there was a new entity described, which was subclinical AKI, where damage markers have gone up, but the creatinine and urine output haven't changed yet. And then finally, the worst outcome in all cohorts that have been looked at is those who have both AKI by, say, KDIGO criteria and elevation of one or more damage markers. And these are who we know clinically as patients with acute tubular necrosis. The outcomes clinically are intermediately worse than no dysfunction or no damage if you've got either subclinical AKI or pre-renal. The outcomes are always worse with AKI and evidence of damage. And we've kind of evolved the continuum of what we think about for AKI to involve recognizing that there is a functional AKI in things like cardiorenal syndrome, pre-renal azotemia, hepatorenal syndrome, that may be reversible and doesn't have damage markers. But there are also damage markers in subclinical AKI that precede AKI. And indeed in ATN, you can have both damage and dysfunction. And work has continued on this. There are only 2 biomarkers that have made it to clinical use. The NephroCheck test, which is TIMP2 IGF-BP7 in the US and in Europe and in other parts of the world now. And in less use, I would say, NGAL, which I'll make some more comments about now. We haven't published this yet. It's under review in a journal at the moment. But with Stephen Duff, the fellow I mentioned, we've been looking at, in an unbiased way, a fairly large ICU cohort where we sampled patients every day for a week to look at what predicted when AKI developed, whether the AKI worsened. Was there death, dialysis, or progression to a higher stage? And as you can see, there are lots of markers of damage that were higher in the progressors than the non-progressors, and looked at in an adjusted analysis of odds ratios for progression, accounting for creatinine and urine output in the adjustment. You can see that several of the markers independently predicted progression. And we're continuing to dissect which ones perform best, and we'll publish this soon, I think. But we've decided to go beyond simple research. We wanted to go into implementation of biomarkers. And in one of our 2 hospitals in our university system, last year we got agreement with clinical biochemistry that we'd implement NGAL testing on the renal consult service. And again, this is just under review. We decided to audit rather than study the first 50 patients and simply publish what happened. And the findings have been interesting and hopefully will be published soon. You couldn't tell from looking at the patient up front based on their serum creatinine or urea or FeNA, whether they were going to have transient AKI resolving in 48 hours or persistent AKI. There was a trend towards Fe urea being useful, and urine NGAL, again in limited numbers with limited power, was clearly higher in those who had persistent AKI, but not statistically significant in small numbers. But if we took out patients with UTIs, where leukocytes also raise NGAL, there now was a significant prediction of who would have persistent AKI versus transient. And if we adjusted NGAL for urinary concentration by indexing to creatinine, whether or not there was UTI considered, but particularly of UTI considered, we definitely got higher values in progressors, significantly so. We also looked at plasma NGAL, which we found less useful. And we've continued this audit as the service uses the test, just doing urine NGAL ever since. And we're going to sum up over the summer what maybe the first 100, 150 cases are like. But in this spider plot, you can see that looking at median levels at the time of diagnosis, Those that were hypovolemic or had functional syndromes like hepatorenal and cardiorenal syndrome had much lower levels than those who had intrinsic AKI, glomerulonephritis, ischemic ATN, or nephrotoxic ATN, who got up to the several hundreds. And I think this has been a useful assessment clinically of whether we're getting value for the test. So hopefully we'll report on that more in the future. Moving on from diagnostics, obviously you're familiar with the KDIGO management guidelines. And one thing that's changed in the past few years is that with the critical care trials of early goal-directed therapy failing to prevent AKI or RRT incidents, we're becoming less focused on kidney perfusion and trying to look for other approaches to modulate kidney damage. We've also begun to use biomarkers to phenotype patients in clinical trials and enroll patients with true kidney damage if possible. And the Pravaki study in cardiac surgery, they found that applying the KDIGO bundle, including functional hemodynamic monitoring, reduced the incidence of both overall and severe AKI, and they've just published a multi-center validation with similar results. So hopefully we'll see this approach used more in clinical practice. Another cohort that I've been involved in as a co-PI for years is the akinesis cohort of heart failure patients being hospitalized and looking at their cardiorenal syndrome. And what's been interesting in the heart failure literature is we're finding that all changes of creatinine in AKI are not created equal. And that in fact, the dominant determinant of outcome in acute heart failure is not whether your creatinine goes up with worsening renal function. It's whether you decongest the patient or not. That patients, and look, this is looking at these 900 patients, looking at whether they decrease their BNP 30% or not, and looking at the impact of in-hospital mortality. And those who don't decrease their BNP are the ones with various definitions of AKI who have by far the worst clinical outcomes in terms of, in this case, in-hospital mortality. Whether or not their creatinine goes up wasn't really relevant to both in-hospital mortality or, in fact, longer-term one-year mortality. There is an interaction in non-decreased BNP if there is worsening renal function as well. So these are patients with AKI who also have failure to decongest, and they are the worst outcomes. But even if you have WRF and you have decongested, the WRF doesn't impact the outcome. And I think this is an interesting finding. So in heart failure, it may be that the relevant biomarker is actually BNP and decongestion. And if the price of that is some elevation of creatinine, maybe that's a price we have to pay, or even move on to ultrafiltration if we can't do it with diuretics. In terms of other novel therapeutics, we don't have time to go everything that's a candidate, and I see you have 2 talks later in the conference on that. But there are lots of things that have moved, thankfully, into phase 2, and in some cases, like alkaline phosphatase and septic AKI, which I've been involved with, along with Professor Mehta, that's even moved on into a phase 3 mortality trial. So we're starting to see novel agents coming through into clinical trials, but I have to say we haven't seen one that's proven to work yet. For the remainder of the time I have, I wanted to talk about renal replacement therapy, where we've obviously had guidance on dose for a number of years, and I won't revisit that, but we've had a weakness in terms of knowing when to start AKI. The KDIGO guidelines, when we did them in 2012, were very generic. Start it if you have to, basically, and otherwise consider the clinical context. And most of us have operated for our whole careers in this conservative way of starting if we have to, but many felt we should be more aggressive and prevent complications of AKI. And we had a lot of retrospective case control studies I won't revisit, but we've had now several prospective studies, only one of which, a single center trial in Germany, showed that early initiation of CRRT in AKI improved survival. Most importantly, within the past year, and we participated in this trial, the START AKI trial, in by far the biggest study, has shown no improvement in survival in starting early. And in fact, not only was there no improvement in survival, but in fact, there was a significant increase in dialysis dependence at 90 days and therefore new CKD or worsening CKD, which might have come at the benefit of shorter ICU time, but clearly, in addition to the failure to improve mortality, leaving patients dialysis dependent when they mightn't have needed renal replacement therapy is a major concern. Of more concern is that there were more adverse events in the accelerated group who started early. There was more hypotension, there was a trend towards more arrhythmias, more electrolyte disorders, and although there was a significant difference in bloodstream infections, there was a trend to that too. So the literature has now suggested that we may be harming patients by being aggressive with renal replacement therapy initiation before it's needed. One of the critiques of the START-AKI is that over half the patients who met the criteria weren't randomized because the caring doctors were asked whether they were feeling that there was equipoise that they could be randomized. If they said they needed mandatory urgent renal replacement therapy, they weren't randomized. If they felt that they simply didn't think they'd progressed to need RRT, they weren't randomized either. And Sean Bagshaw sent me this personal communication to say, what happened to those patients who were eligible but not randomized? And in fact, they found that the clinicians chose correctly. Those in whom they said they shouldn't randomize because they weren't going to need it weren't as sick by SOFA score, and very rarely, 11% of cases, progressed to require RRT. And those they said were emergent, they were sicker patients, and obviously it's a self-fulfilling prophecy that when they said they urgently needed CRT, they mostly got it. And those who were randomized had outcomes in between the two, which again is not surprising. Most recently, the French group, which did the Akiki trial, one of the trials of early versus late, which didn't show a survival benefit, also did a further randomized trial in a relatively small group of 100 or so patients with stage 3 AKI who'd been oliguric for 3 days and who had a pretty high BUN already, to say they'd start in their traditional delayed format like their previous trial, or would wait until they either needed urgent renal replacement therapy or their BUN went up further to over 140 for 2 consecutive measurements. And at randomization, these delayed versus very delayed patients had similar lab tests. And they didn't find a difference in survival, RRT-free days, I should say, at day 28. But of concern, they did find a trend towards higher mortality in the group that got very delayed initiation, 55% versus 44%. And in a multivariate analysis, the hazard ratio was significantly increased for more death at day 60 in those who got very delayed initiation. So we've now found that too early is bad, and clinician judgment should be used as to when to start. And although not definitive, a suggestion that there may be a time that's too late when mortality starts to go up. It should be said that they didn't seem, in looking at the details, to get more hyperkalemia or unmanageable acidosis as a cause for these late initiations. So it may be the distant organ effects and the immune effects and the other effects of azotemia that are harder to quantify. So the update on recommendations is probably the traditional list is correct. But in looking at what Bagshaw, Ron Wall, the other PI of START-AKI, and Eric Hosta came out with, it's still a common sense recommendation. Don't start unless it's an emergent indication, but keep trying to optimize the patient, and indeed do start if an emergent indication emerges. But the other caveat is that we have to keep a mind towards the adverse effects of fluid overload or uncorrected acidosis or dangerous trends in hyperkalemia. And clinician judgment is always going to win out in the end. But clinician judgment shouldn't be over-aggressive in starting someone as soon as they've got severe AKI, because that hasn't been proven to be helpful. So I think we're still okay on time. So I'm going to summarize the conclusions on what I decided to talk about today. That in the diagnosis and staging, as was pointed out by Dr. Fernando, it's of great benefit that we've got standardized diagnostic and staging criteria for both clinical practice and research. I think we'll fill in the last gap there with reconciliation of AKI, AKT, and CKD classification. And already in the latest ADKI meeting, which we held in Italy a couple of years ago, published in JAMA, which I didn't have time to go into, they've already recommended using biomarkers for these diagnostic approach to AKI to get further sophistication and understanding how to use them. We're also going to use functional and damage markers of increased validity to target both our standard and novel therapies. And I did want to mention, obviously, it's hard to ignore COVID in any presentation at the moment. I know Dr. Vijayan is giving a specific presentation on AKI and COVID, but I did want to suggest that one of the benefits of the pandemic has been that research has sped up in the use of things like platform trials like REMAP-CAP for pneumonia in AKI, and we participated in this trial, and I think it's of great benefit. So these are just some acknowledgements that I won't read, and I hope that you found this an interesting presentation, and I want to thank you all for your attention. Thank you.
Thank you, Professor Murray. I understand the limitation of time and the topic being given to you, but still you justified in giving key messages, what has changed in the last 2 decades. We have no question still on Q&A, so I will wind up and hand over the organizer to the next talk.
And I will be happy to take emails if anyone wishes to send me them.
Sure.
Thank you.
Thank you.
Thank you, sir. I would like to start our next topic, AKI in tropics. I would request Professor H.S. Kohli to kindly introduce Dr. Vivekanand Jha.
Good evening, everybody, and welcome to this AKI session. I think you have asked me to introduce Professor Vivekanand Jha. You should not have used these words. Dr. Jha doesn't need any introduction. Yes, he's a close friend. He's a professor of nephrology at PGI-MER, and he's holding so many positions internationally. And now he will be talking about AKI in tropics. This is a topic which we have been listening for last 5 decades, but I'm quite sure Vivek will add some twist and will come out with the really thought-provoking ideas about AKI in tropics. Vivekanand Jha, please.
Thank you, Professor Kohli, for that very kind introduction. And let me just get started. I hope you can see my screen. Can you just nod or say yes?
Yes.
All right.
Yes.
Thanks. So I also extending my thanks to Vinam and other colleagues at Sir Gangaram Hospital, the organizers of this meeting, for asking me to come and speak on this specific topic. As you said, Professor Kohli, we have been hearing about tropical acute kidney injury for a long, long time. But let's just step back and put it in perspective. We know that AKI is a global burden and has been recognized as such, as was clarified by Professor Murray. And look at the estimated burden of acute kidney injury with progression to chronic kidney disease and death across the world. And on the left, you have this figure of 2 million in developed countries. And on the right, you have that figure of several folds higher in the developing country or low middle income countries, which fall mostly in the tropical zone. So right away, you can see the disproportionate burden of acute kidney injury in the tropical countries. And what are tropical countries? So tropical countries are those shown here in the red band, which is between the tropics of Cancer and tropics of Capricorn, which is 33 degrees north and 33 degrees south of the equator on both hemispheres. And if you look at the same definition of tropical countries in terms of them being mapped out, the countries that are colored here are typically categorized as tropical countries, which you can see span from Latin America to Africa to parts of South Asia, Southeast Asia, and on Oceania region as well. So the tropics make up about 40% of the planet's surface and 40% of the population. But please note that we are in a very moving time, characterized by climate change. And it is now estimated that tropics are set to expand. And in less than 10 years, the population, which is 40% today, would have expanded to 50%. So 1% growth per year in the next 10 years. So what is different and unique about the tropics? So the difference and uniqueness is the heat. So tropical zone is the zone where all 12 months have mean temperatures above 18 degrees Celsius. It is humid. So you have in the middle the equator, and you can see 30 degrees north and 30 degrees south on the x-axis, which more or less define the tropical zone. And you can see the amount of rainfall is highest in the tropical zone. So this is a tropical climate characterized by heat, humidity, and also salinity, which I didn't talk about. And all of these have their effect on the local flora and fauna. They increase the prevalence and diversity of disease-carrying vectors and parasites. They bring out venomous snakes and biting insects. They also, because of the heat, the humidity, etc., give rise to profusion of flora, which look really beautiful when you come and visit, but they could contain unusual herbs, which are also nephrotoxic. So sepsis has a different definition in the tropics as compared to that you see in temperate zones, where sepsis is typically what you encounter inside the hospital. So sepsis in the tropical countries is, as I said, strongly influenced by the climate and living conditions. It develops most frequently in the community and is as a result of locally prevalent infections. Severe sepsis in the tropics carries a very high mortality, more than 80%. And its nature and course is also affected by cultural factors, literacy, superstitions, living conditions, access to healthcare, nutritional status, etc. And there are a number of unique problems which we encounter in the tropics. These conditions are managed in a non-evidence-based way, which we saw a lot in the COVID times. And there is frequent drug resistance. So in a summary, if you compare acute kidney injury in the tropics to acute kidney injury that is encountered in temperate climates, the basic difference is one of setting. In tropical countries, it is community acquired, whereas in temperate countries, it is hospital acquired. Populations are relatively younger, and the clinical setting is one where you have tropical infections, volume loss due to diarrhea, obstetrical accidents, snake bites, insect stings, secondary to consumption of nephrotoxic plants or animal products. Acute kidney injury develops in the communities and clinics, is really recognized very late and presents with complications and imminent need for kidney replacement therapy, which is very different from what you see in countries of the temperate climate, where the affected population is usually hospitalized elderly in the ICU with multiple comorbidities. So as I'm sure you have recognized the focus on sepsis. So we see a number of tropical febrile illness syndromes, which are characterized by acute kidney injury. And we need to recognize these patterns and arrive at differential diagnosis, because often treatment needs to be started empirically. And in this paper with Dr. Emmanuel Birdman, we published this syndromic presentations, fever along with jaundice, conjunctival suffusion, thrombocytopenia, respiratory symptoms, and so on and so forth, and possible etiological diagnosis that need to be considered in these different situations. Of course, just because we have to consider these diagnoses doesn't mean that those diagnoses are certain. We still need to do tests. And this is the spectrum of acute febrile illness and acute kidney injury reported from Christian Medical College, Vellore in southern India. You can see the most common illness was strep typhus, followed by malaria, enteric fever, dengue. And you can see the distribution of cases, all cases in the blue bars, and those with acute kidney injury in the orange bars. Of course, the number of cases with acute kidney injury is lower than the number of all cases, but still the pattern holds more or less. And still, in the end, you have to recognize this undifferentiated acute febrile illness, which presents the real headache for management. Diagnostic facilities are limited, and this is an example of one situation where we encountered a challenge in identifying patients who we thought were presenting with strep typhus, but we didn't have any reliable diagnostic modalities. So we actually decided to go ahead and set up a PCR test in our own lab, and we recognized that scrub typhus was really responsible for a significant proportion of cases. More than half of the cases with acute kidney injury related to febrile illness were due to scrub typhus. And you can see the breakdown in the table on the right. Now, we also see a number of unusual conditions, which some of us would have seen, others may not have. I thought it is useful to illustrate because of all the conversation that is happening about black fungus in the context of COVID, is something that the nephrologists have been aware for a long time. And this is one case report that we published in Kidney International of a 23-year-old male carpenter who presented with a short history of fever, swelling over the ankle, dull ache in right flank. It presented with recent onset hematuria, reduced urine output. And when we examined the foot, this is what we found. Because of our experience, we immediately went ahead and did a contrast enhanced CT scan. And this is what we found. You can see the completely non-enhancing right kidney and a patchy enhancement of the left kidney. Because of the experience, again, we were able to very quickly arrive at a diagnosis, but for many, it may not be so apparent. We went ahead and did actually a bilateral nephrectomy in this person because we knew what the diagnosis is going to be. And this was the diagnosis. We saw a complete necrosis of the kidneys, ischemic necrosis, and in the necrosed kidney on histopathology and special staining, we found abundant hyphae of mucor. So this was renal mucormycosis. Here is another unusual presentation published by Dr. Mahesha from Bangalore. He had a patient present with nephrotic syndrome whose biopsy were done and sent to him. And while he was examining the biopsy, he found this beautiful microfilaria in one of the glomerular capillaries, suggesting this nephrotic syndrome could have been related to a microfilarial infection. But Professor Kohli talked about something new that we must consider as practitioners of tropical nephrology. And I would draw your attention to the upcoming threat, which for many of us and has been said by WHO to be the biggest threat to human health in the coming years, which is the threat of climate change. And what would it mean for infection and acute kidney injury? According to the Lancet Commission on Climate Change, tropical countries are going to be the worst affected because of climate change, and it named a few countries, and these countries are India, Indonesia, and Bangladesh are the greatest threats. This is a picture from the city of Chennai, and this looks like really a rural area because Chennai is now experiencing frequent episodes of these flash rains and flash floods that produce these kind of scenes in not too infrequent circumstance. So what is likely to be the effect of climate change and acute kidney injury in the tropics? So this is going to be as a result of further increase in air temperature, effect on the quality and quantity of drinking water, but also there will be a large-scale migration and displacement of population, as you saw in the previous picture. This is going to contribute to air pollution, and of course, climate change has been blamed for increase in the frequency of pandemics. We are also seeing perhaps a change in the virulence of many of the very, very familiar organisms. One of those organisms that we have been familiar with for a long time in India is Plasmodium vivax. So when Dr. Kohli and I were doing our medical residency, if a patient presented with malaria and acute kidney injury, we automatically assumed that this would be falciparum malaria because vivax was thought to be the benign form of malaria. And so my boss at that time, Dr. Chug, would fail you in your exam if you made a diagnosis of vivax malaria and acute kidney injury. But now, a large number of cases with Plasmodium vivax associated acute kidney injury have been documented. And therefore, it is quite possible that the virulence of the organism is changing. Similarly, a new type of malaria parasite has been identified associated with acute kidney injury, which is the Plasmodium knowlesi, and this has been recognized initially from Malaysia, Thailand, etc., and is being now identified in India as well. So the pattern of infections is also changing in the tropics, and something that we need to be aware of. Next then, what is going to be effect of acute kidney injury on other types of kidney disease? And Dr. Murray talked about acute kidney disease and continuum into chronic kidney disease. So almost all of us have been now familiar with the conversation around the chronic kidney disease of uncertain etiology and the chronic kidney disease hotspots around the world. And these are the hotspots that have been described from different parts of the world. And once again, if you can recall the previous map that I showed you of the tropical countries, you will immediately recognize that almost all of these countries fall in the tropical zones. So the CKD hotspot is again a tropical illness. So why am I talking about CKD hotspot in an AKI session? It is quite possible that CKD of uncertain etiology is actually a long-term consequence of multiple recurrent episodes of acute kidney injury. So there have been these speculations, and it has been suggested that infections such as leptospirosis, hantaviral illness can be possible causes for chronic kidney disease of uncertain etiology. There has been a speculation from Dr. Chi-Wei Yang and in his lab from Taiwan about leptospirosis. And in PGI, Dr. Vivek Kumar has collected data and kindly shared these data with us of 272 patients with acute kidney injury, in which a number died or left against medical advice. Some of them were lost to follow-up. But out of 148 patients who returned 4 months later, almost a fifth had EGFR less than 60 or UPCR more than 500, which would qualify them for a diagnosis of chronic kidney disease. So then coming to the end, we must talk about what should we do about this then as a healthcare community. We need to really focus on all aspects of healthcare system, starting from service delivery, healthcare workforce, information systems, making sure that there are access to essential treatments, healthcare financing, but more than anything else, we need to improve our leadership and governance. So these are the pillars of how to prevent acute kidney injury. We can talk a lot about treatment, but prevention, I think, is the key in the tropics. And we need to deal with communicable diseases through clean water, malaria control, immunizations, etc. Environmental toxicity by improving building quality, access to antivenom for snake bites, etc. And to deal with obstetric complications, we need to continue to improve our obstetric care. So then, my dear friends, here are the take-home messages. Acute kidney injury in the tropics and essentially in other developing countries as well is a different disease compared to the one that is seen in countries with a temperate climate. Tropical AKI is irrevocably linked to the local ecosystem and the local cultures. The incidence and pattern of tropical AKI reflects the unfinished public health agenda in our countries. The presentation and outcome of tropical AKI is influenced by system level factors rather than individual factors. We need more information and awareness in the community to be able to tackle AKI in a combined health system-wide approach. But we have to remember that the upcoming climate change is going to have a major impact, and there is a danger of us slipping on the gains that we have made. We have already slipped on a number of gains during the COVID pandemic, and climate change will produce further losses to us. We need to continue to do more research, and I would say that tropical acute kidney injury is a neglected disease, and we need to focus more on this as a research community. I would stop here and thank you for your attention.
Thank you very much, Professor Jha. I think Dr. Jha has drawn our attention that the world is becoming like us. 50% by 2030 will be tropics, tropical area, and a lot of illnesses will be there. And I think one big message which is coming out from the last two talks is, I think as a nephrologist, which I can get at is, that which he referred to in one of the study, which we gave it to our MD student, that after a follow-up of 6 months, like 20% of them, they had not recovered. So this, at least this message to the physician and the general population as a whole, that AKI cannot be taken so lightly, that potentially or a totally reversible. That word from the textbook has to go with time at least. Yes, tropics will have their own problems, since we do not have any question in the question and answer session. So with that, thank you very much, Dr. Jha, for a wonderful, stimulating talk as usual. And I'll hand it over to the organizer.
Thank you, sir. After the great session, I would like to start our second session, Preventing AKI. For this, I would like to invite our chairperson, Professor Gopal Krishnan, Director, Institute of Nephrology, Madras Medical College, Professor Himanshu Shekhar Mahapatra, Head of Department of Nephrology, Dr. RML Hospital, New Delhi, Dr. Sunil Prakash, Director, Head of Nephrology and Renal Transplant Service, BLK Super Speciality Hospital, New Delhi. I would request Professor Gopal Krishna to introduce Dr. Nupur Uppal.
Very good evening. I'm Dr. Gopal Krishnan. I have great pleasure in introducing the next speaker, Dr. Nupur Uppal. She is the Director, Cardiorenal Services, Division of Nephrology and Hypertension, Zucker School of Medicine at Hofstra, Northwell, New York. And the topic for her is acute kidney injury in cardiorenal syndrome. It is an exciting topic in the sense that the complex interrelationship between the kidney and heart, both in health as well as in disease, is an area of intense research. I don't think we have really understood the complexity of the relationship between these two organs. And we do come across more and more of AKI in the cardiac critical care setup. The floor is yours. Like others, I'm eager to listen to you, Dr. Uppal.
Hi, everybody. A very, very good morning from New York. Thank you, Dr. Gopalakrishnan, for the introduction. And I would also like to thank the organizers for the AKI Update Conclave for inviting me here. Before I start, I would want to extend my big salute to the entire medical fraternity in India for dealing with COVID crisis over the past 2.5 months. And finally, the numbers are getting better. So all over the world, we all are glad and do send our wishes and thoughts to you. So I'm just going to start with my presentation. I don't have anything to disclose. And the objectives for our talk today are going to include discussion about pathophysiology of acute kidney injury in decompensated heart failure. We'll go over evidence-based management strategies for patients with cardiorenal syndrome. I'll try to introduce some novel concepts and emerging literature in terms of newer strategies of management, and eventually discuss some of the research opportunities. So let's start with a case. I'm sure most of us must have encountered a similar case at some point for sure. So we have a 48-year-old female with known history of heart failure with reduced ejection fraction of 30% who gets admitted to the hospital with fluid overload and AKI, and her creatinine increases from a baseline of 0.7 to 1.3 milligram per deciliter on admission. She's initiated on IV furosemide, eventually converted to a drip. Her creatinine continues to rise. The parameters which we have available include MAP of 68, heart rate of 95 with a sinus rhythm. JVP is elevated at 18 centimeters. She does have significant presence of edema extending to the thighs with warm extremities. BNP is elevated at 5,000. Urine sodium is less than 20. Serum sodium is 124, potassium 3.7, chloride 76, bicarbonate 32, and BUN of 67, the creatinine has rose to 2 now. The point of care ultrasound done for lung shows diffuse B-line pattern. So what would be your next plan of action? Would you want to change to alternate loop diuretic drip like Bumex? Would you want to start another diuretic like acetylzolamide? Since the creatinine is going up, should we hold ACE, ARBs, or any aldo inhibitors in this setting? Add a thiazide diuretic? Hold all the diuretics completely with the uptrending creatinine, or get a nephrology evaluation for ultrafiltration? So I hope by the end of this lecture, we'll be able to come up with the answer, and hopefully all will be able to derive a management plan in patients who have AKI in the setting of cardiorenal syndrome. So just talking about the cardio-renal connection, it actually goes way back to 1830s when initially Sir Richard Bright had described structural changes in kidneys done on the autopsies in patients who had died due to cardiac failure. Then it was Arthur Guyton between 1970s and 80s who did establish the connection between heart and the kidneys, and did have a lot of literature on how heart and kidneys play a role in maintaining hemodynamics, maintaining blood pressure. However, it wasn't until early 2000s that a real attempt to classify cardiorenal syndromes was made. Right now, the accepted, the most widely used definition for cardiorenal syndrome is they constitute disorders of heart and kidneys whereby acute or chronic dysfunction of one organ may induce acute or chronic dysfunction of the other. And actually, cardiorenal syndrome by the Adult Dialysis Quality Initiative has been classified into 5 different types. This is a classification from way back in 2008, where type 1 and type 2 are the cardiorenal syndromes where acute heart failure leads to an AKI, and a chronic heart failure in type 2 leads to progressive and permanent CKD. Type 3 and type 4 can also be classified or called as renocardiac syndromes, as these syndromes you have pathology in the kidneys, whether it's acute or chronic, leads to acute or chronic heart failure. And type 5 are the secondary causes which can lead to both heart and kidney dysfunction like sepsis, amyloidosis, diabetes, etc. So let's talk why does this happen? And because of the time constraint, I'm going to limit my talk to type 1 cardiorenal syndrome, which is occurrence of AKI in the setting of acute cardiac dysfunction. So the old school thought used to be that this was a dysfunction of forward flow, where inability to generate forward flow would eventually lead to RAS activation, causing increase in vasopressin, fluid retention, and finally worsening of pump failure further. However, this hypothesis was not reproduced in any of the studies. And it was actually in early 2000s, what was seen was that the worsening renal function in patients with heart failure was actually related to an increase in CVP as opposed to cardiac index. And similar results were also seen later, where again, it was shown that cardiac index is not a dominant driver of renal dysfunction in heart failure. This did lead to other thought processes, other hypotheses of what might be going on. And because we now know that it's related to an increase in CVP, what exactly is happening is that because of increase in your central venous pressure, there occurs an increase in the renal venous pressure, thereby causing a decrease in the renal perfusion pressure, and that's the reason why these patients may be developing AKI. The other concept which I want to introduce is the concept of renal tamponade. This was a study which was done that measured intra-abdominal pressures in patients with heart failure. And what was seen was the ones who had higher intra-abdominal pressures over 8 millimeters of mercury did have higher baseline serum creatinine. And also the change in intra-abdominal pressure, if it was a higher change, there was actually a greater degree of change in the serum creatinine. So definitely high intra-abdominal pressure is elevated with an AKI, with an increased creatinine, and this might be something similar to cardiac tamponade, a phenomenon like renal tamponade. Besides the theory of decreased perfusion and increased venous pressure, there is also a lot going on neurohormonally and definitely a lot of immune-mediated inflammatory crosstalk, which can lead to AKI in a situation of acute heart failure. So next comes how to diagnose a cardiorenal syndrome. And most important step, like any other patient, is to have a good history and physical exam, especially assessment of volume status is very important, which may become challenging in certain situations. Of course, lab parameters, imaging studies, and invasive hemodynamics measurements may also help in assessing volume status better. Just a word on role of biomarkers. So now we know that there are different types of kidney biomarkers available. There can be the markers for glomerular injury, markers for tubular injury. Among these markers, definitely cystatin C is considered better than creatinine just because of its it's being able to get freely filtered and completely reabsorbed. And then there also has been role suggested of measurement of serum as well as urine NGAL in patients who develop AKI in the setting of cardiorenal syndrome. We also now have something called as NephroCheck, which measures the tissue inhibitor of metalloproteinase 2 and insulin-like growth factor binding protein, again a marker of kidney injury that can be used and maybe even get more readily available in the future, helping in detecting the acute kidney injury. Coming to imaging modalities, of course, echocardiogram is important to see what's going on with the heart, what's the EF, are there any valvular abnormalities, any hypertrophy, etc. There has been role suggested of measurement of intra-abdominal pressure, measurement of your IVCs, whether it's collapsed or whether it's plump. Bioimpedance vector analysis can also be used to assess volume status in patients who may be fluid overloaded. And then renal ultrasound definitely stays something important. And we'll also discuss about POCUS of the lung, its role here. So renal ultrasound, first thing, of course, which it may help is distinguishing the acuity versus chronicity of kidney injury in these patients. And the other two indices which can be measured are intrarenal venous flow as well as renal venous stasis index, which we can do with the help of a renal ultrasound. So intrarenal venous flow, when measured and at the same time when it's looked what the right atrial pressure in these patients is, what has been seen is that patients who have a normal right atrial pressure, the intrarenal venous flow has a continuous pattern in them, and those who have high right atrial pressure usually present with a discontinuous pattern. Not only this, the discontinuous flows are also associated with poor outcomes in these patients. Next is the concept of renal venous stasis index, which again may help in assessment of a congestive state. And if the renal venous stasis index is high, it just shows that the patient is congested when you may not see evidence of congestion on physical exam. Then role of lung ultrasound. We all are now aware presence of B lines do indicate volume overload for this patient. But another important concept is that actually B lines may also appear before the onset of symptoms, before development of symptomatic acute decompensated heart failure. So that's where this may come into role. Role of cardiomems has not been described in patients with CKD or those with acute cardiorenal syndrome, needs to be investigated more. And your pulmonary artery pressure measurements based on ESCAPE trial did not show any benefit in terms of decrease in incidence of AKI or effect on renal function. However, definitely might be warranted in difficult situations where patients clinically may be hiding the fluid overload. So let's talk about management now. The treatment goal here, it's very important to understand, is to achieve decongestion as soon as possible, which can be done either by medically managing them with diuretics or using other strategies like ultrafiltration. And if they have a clearance issue going on, we can always go ahead to renal replacement therapies. So loop diuretics are the first choice of agents to decongest these patients. This is just to give you an idea that the loop diuretics, when they start acting, the effect is little until they attain a threshold value, and then they get a ceiling effect. However, this dose response curve gets shifted towards right and downward in patients with acute decompensated heart failure. So these drugs may not act at the same dose for patients who have acute decompensated heart failure. Next question is, what is the best route and dose for using loop diuretics? There has been no difference seen between use of bolus versus continuous infusions when these diuretics are used in an equivalent dose. You can start these patients on a loop diuretic, but then comes the concept of diuretic resistance. There is no universally accepted definition of this, but basically means that patient who was responding to a good dose of diuretic earlier has stopped responding now, and this can happen due to multiple mechanisms, can get worse in patients with acute decompensated heart failure and ones with acute kidney injury or underlying CKD as well. How can you overcome diuretic resistance? By using sequential diuretics. And the theory behind this is just to block each and every part of the nephron, which will give you a better diuretic effect and exponential diuretic effect. So basically, we just need to teach our old, good old diuretics these new tricks. What to do with diuretics if the patient starts developing acute or further rise in the creatinine level? So it has been seen that patients who achieved hemoconcentration or who had good decongestion with the use of diuretics did have a rise in serum creatinine or worsening renal failure, but survival-wise, their outcomes were much better. So you can actually have permissive AKI or hypercreatinemia in these patients, as it's going to give a survival benefit. What about the ACE ARBs and ARNIs like Entresto, sacubitril, valsartan now? It has been shown that actually sacubitril valsartan at 48 months has a lesser effect on change in GFR as compared to enalapril. So both of these agents, all these agents can be continued with caution in patients who develop acute kidney injury because they do have long-term survival benefits. There has been an upcoming emerging role of chloride being suggested as a worse prognostic indicator, even worse as compared to low serum sodium level, and also has been associated with poor diuretic response. Then the concept of using hypertonic saline just means that we want to give these patients a high sodium load. And the theory behind this is if you're giving them high sodium, they are going to have more sodium chloride in their system, and this can lead to pushing of fluid from extracellular to intravascular space. What we have seen here in the US by using 3% saline is that there is always a concern these patients may develop worsening of fluid overload. However, their supplemental oxygen use did not go up. The change in serum sodium at 6 hours was within expected limits, but the potential effect which was seen was that there was a significant increase in urine output as well as a significant decrease in the weight from their baseline on admission. Also, the overall diuretic response seen in terms of increase in urine output was much better when these patients were given 3% saline along with use of diuretics. So stepwise approach for medical management of patients with type 1 cardiorenal syndrome includes what we practice here is to start them with a loop diuretic, and usually we start with an IV push, assess for urine output. If the urine output remains low, we add another diuretic. It can be anything between thiazide, it can be spironolactone, depending on if we want to to also change the electrolyte levels. And then if the urine output still remains low, we do consider hypertonic saline, which has been shown to give good results. Role of ultrafiltration, so there has been benefits suggested, advantages suggested, however, no randomized control trials so far that could suggest that it definitely helps or it changes mortality or survival in these patients. And KRAS heart failure was actually the trial which did show there was a significant increase in serum creatinine for patients where ultrafiltration was initiated early on without any difference in survival or overall outcomes in these patients. Literature on renal replacement therapy is still lacking. We still need to dig more into it, whether one modality of renal replacement therapy is going to be better over the other, or whether early versus late initiation in patients with cardiorenal syndrome is going to be helpful in terms of renal recovery or overall survival. So just to summarize, an acute heart failure patient may develop acute kidney injury due to various mechanisms, including hemodynamic derangements, inflammatory crosstalk, and neurohormonal activation. Once detected, we start with medical management. If that doesn't work, we do take into account the role of renal replacement therapy. And of course, once the patient is decongested, our goal is to help them get off dialysis as soon as possible. A lot of potential research opportunities here. We may be able to better define cardiorenal syndrome and AKI in cardiorenal syndrome because most of the trials use rise in creatinine as opposed to decrease in urine output or other biomarkers in these patients. And definitely more to be known in terms of diagnostic, treatment strategies, dialysis modalities, and also importance of palliative strategies in these patients. So we learned about these new concepts of renal venous hypertension, allowing for AKI to develop in these patients, given the survival benefit long term. We can continue using ACE, ARBs, ARNIs in a situation of AKI in patients with cardiorenal syndrome. Goal is to attain and maintain euvolemia as soon as possible. And the last and most important is that salt may be actually a solution here, not a problem. So we may in the future want these patients to actually take more salt in. And the sodium heart failure trial that completed their enrollment last year, we should be expecting the results sometime soon. Thank you very much.
Thank you so much, Dr. Upal. That was fantastic. Within 20 minutes, you were able to cover almost all the important concepts about cardiorenal syndrome, AKI. Particularly the important message that you have driven home is the more important rider in deciding the occurrence of AKI is renal venous congestion. That's very important. And also another thought-provoking suggestion is that role of 3% saline in resistant condition. My point is that, is there any role for SGLT2 inhibitor?
So yes, that's a good question, Dr. Gopalakrishnan. Yes, I mean, like, SGLT2 inhibitors, although still they are, at least in the US, they are still marketed under anti-diabetic agents. So mostly FDA approval is for patients who have diabetic kidney disease. But now we do know with the newer trials like DAPA heart failure, EMPEROR, that included dapagliflozin, empagliflozin, for patients with heart failure, even without diabetes or without kidney disease, they did have better outcomes. The role in an acute kidney injury situation, as far as data is concerned, we still don't know that. But of course, they are potent diuretics. So, we still can use them to augment diuretics. And there has been some role suggested that with the use of SGLT2 inhibitors, they may act on the clotho receptors and maybe even help in preventing AKI to develop in patients who may be in decompensated heart failure, but yet not in AKI. But we still need more trials, more data on it. But definitely a potential diuretic and should benefit these patients.
Thank you so much. And a word about acute peritoneal dialysis in our center in Madras Medical College. Quite often we resort to that. It's an acute intermittent peritoneal dialysis in a hemodynamically unstable patient. It's quite rewarding in certain situations.
Yes, yes, absolutely, definitely. I mean, given hemodynamics, it is definitely considered to be better, especially in patients who may have like, you know, hemodynamics that are not that great, especially for these patients. It's just that in the US, still the primary modality to be used for patients who have AKI, and we still go with intermittent hemodialysis or CRRT. Acute PD is not something which is regularly performed. But there is actually data for patients who are on chronic PD. At 6 months, people have seen that there was a decrease or actually improvement in their NYHA class of symptoms for patients who were on chronic PD and had acute heart failure along with ESRD or advanced CKD stages.
Thank you so much. And the new concept on chloride, it's a kind of a paradigm change in the thinking. We've been thinking that chloride is kind of nephrotoxic.
Yes. So actually, like, we used to have one of our fellows, and he used to tell us that his favorite electrolyte is actually chloride, because nobody is going to call you or wake you up in the middle of a night for a high or low chloride level. But I think now, with the emerging literature, and as you are saying, it may have a potential role too, maybe even more than sodium. So definitely we'll know.
Thank you so much, Dr. Upal. I thoroughly enjoyed your lecture. Thank you so much.
Thank you. Thank you so much, Dr. Gopalakrishnan. And thank you again to all the organizers.
Thank you so much, sir. Thank you, ma'am. I would request Professor Himanshu Shekhar Mahapatra to kindly introduce Dr. Jaya Kala.
Sir, you're muted. Please unmute. Sir, you are muted. Please unmute.
I'm sorry. She's Dr. Jaya Kala, Assistant Professor, Special Interest in Onconephrology, working in Division of Renal Disease and Hypertension, Department of Internal Medicine, UT Health Center, McGovern's Medical School, and Section of Nephrology, Department of Emergency Medicine, MD Anderson Cancer Center. She has lots of honors. NKF Young Investigator Research Grant Award in 2019, Southeast Texas Research Grant. Her project was isosorbide mononitrate for anti-vascular endothelial growth factor induced kidney injury. She is also editorial member of NKF Spring Clinical Meeting Committee member, and now she will speak on chemotherapy related AKI. Over to Dr. Jaya Kala.
Thank you very much for the kind introduction, Dr. Mahapatra, and thank you for the organizers for allowing me to be part of the session today. I'm going to be sharing my slides. Okay, hold on. Just trying to share my slides. I think somebody else is sharing. I'm not able to share my slides.
Avinash?
Just checking, sir. No, please share. Yeah, it's not saying.
Could you open up my slide deck then?
Okay, just a minute.
Yeah.
Okay, ma'am, we are doing that.
Thank you. All right. Thank you very much. Okay, so we're going to be talking about traditional chemotherapy related acute kidney injury. It's a very comprehensive topic, and I'll try my very best to make it as quick as possible. Next slide, please. These are my disclosures. Next slide. So we are going to be talking about how we classify these traditional chemotherapeutic medications, the risk factors that are usually associated, which make patients prone to the nephrotoxicity. Specific drugs we're going to be discussing about. I won't be able to go through all of them, but most of the ones which I do go through, we will talk about the risk factors, how we prevent nephrotoxicity in them, how the clinical manifestation occurs, and the treatment. Next slide, please. We classify these traditional medications as alkylating agents, antimetabolites, antimicrotubules, agents, anti-tumor agents, platinum-based agents, immunomodulators, proteasome inhibitors, and there are some of the miscellaneous which we won't be going into in detail. Next slide. The risk factors that our patients are usually prone to, which make them at a risk of having kidney injury, are usually intravascular volume depletion. And these risk factors are present in almost all other patients as well, which we come across in our clinical practice or in the hospitals. The use of concomitant nephrotoxic agents also increase their propensity. Underlying cancers which might cause urinary tract obstruction might be another reason why we have AKI. And intrinsic, which is patient-dependent issues, which are either idiopathic, age-related, or cancer-related. Next slide. The drugs which are usually requiring or dose adjustments are almost all the drugs that I've already mentioned about, and I'll be subsequently talking about as well. So nearly all drugs that are being given as chemotherapeutic agents, we'll have to always go back and look at the drug dosing, and depending on the eGFR of that patient at that time, will decide what the drug dosing should be for the next cycle. Next slide. Now coming to specific drugs, cisplatin, which is so commonly used. It's usually used for the solid tumors and lymphomas. Nephrotoxicity is seen in about 30% of the patients, more so in cisplatin as compared to oxaliplatin. And the onset of AKI happens in about 7 to 10 days. It is usually reversible. However, in most of the cases and most of our clinical practice, we found it very notorious to be permanent and causing lasting side effects. Next slide. The mechanism of cisplatin nephrotoxicity lies in the fact that through the organic cation channels, its induction or influx into the proximal tubules results in inflammatory changes within the proximal tubules, which causes changes in the mitochondria, in the renal tubular cells, causing apoptosis and necrosis. That is what results in the acute kidney injury and the tubulopathy. And what we encounter in patients are AKI, proximal tubulopathy resulting in Fanconi syndrome, salt wasting, where they have glucosuria, proteinuria, there'll be increase in potassium, magnesium losses, there will be nephrogenic DI. Some patients even land up having TMA. Next slide. So what are the risk factors that we can prevent in our patients so that we don't allow this occurrence to happen? We need to ensure that if the first cycle of cisplatin, since we're able to see it within a week's time, we need to be dose reducing, hydration needs to be started, and substitution to a lesser nephrotoxic such as carboplatin or oxaliplatin may be done. Supportive treatment is what we have to do in these patients. And as I said, either discontinue cisplatin and switch them to the other platins, correct the hypovolemia that results from the salt wasting, and electrolyte replacements need done. Next slide. Now, this is the hydration protocol that has been recommended. When the cisplatin dose is less than 50 milligram per meter squared, we usually try to do it outpatient setting. Shorter duration of infusion can be done. Hydration and potassium and magnesium supplementation may be required. Next slide. Coming to the next drug, which is ifosfamide, the chloroacetaldehyde part of the metabolite that is being generated by ifosfamide is the one which causes direct nephrotoxicity. In comparison to that, cyclophosphamide, which is another drug which is with a similar background, causes the metabolism of, the result it forms is acrolein, which does not cause AKI. The risk factors with ifosfamide-induced nephrotoxicity is prior exposure to cisplatin and if a dose is more than 60. Next slide. So as you can see in this slide, the site of action of chloroacetaldehyde and the acrolein are the reasons why the proximal tubulopathy happens, and hemorrhagic cystitis is because of acrolein. And so also for cyclophosphamide, which is also producing acrolein, which causes hemorrhagic cystitis. So we see usually AKI, proximal tubulopathy, and nephrogenic DI. Next slide. How do we manage these patients is by reducing their dose. The use of Mesna and N-acetylcysteine and cimetidine has not been proven to be much. It's just merely on case report basis. But the usual treatment again is supportive and electrolyte replacements. Next slide. Now we come to methotrexate, which is a dihydrofolate reductase inhibitor. The AKI is dose dependent and usually seen with higher doses that are used. That is a high dose methotrexate infusion. The doses are usually at 1 gram per meter squared and above. Next slide. So the crystallization of the methotrexate in the tubules is the actual reason for acute kidney injury. And that is what results later on in elevation in serum creatinine. So we start seeing crystallization prior to the actual elevation of the serum creatinine. And as you can see in the urinary sample that we had spun in our patient, these are the crystals that came out in the urine, which are the methotrexate crystals, which are causing the ATN to occur later on, and the direct tubular toxicity that also ensues later. Next slide. Now, usually when the methotrexate is infused, the oncologists go through a normogram where the 2 standard deviation curve, which you see in this dark blue line, is what needs to be achieved. As the serum creatinine has to be looked at almost every 24 hours, we try and see if the methotrexate level falls in between this 2 standard deviation. If it does not and goes more to the right-hand side, the patients are more at a risk of having severe toxicity. And the risk factors of severe toxicity with methotrexate are with higher body mass index, concomitant use of other nephrotoxic agents, which are also released from the tubular areas. If the urinary pH has not been maintained by giving bicarb solution, if IV fluids have not been given enough, that is less than 3 liters per meter squared, or if there is thirst spacing or prior history of any renal insufficiency. Next slide. Now, that's how you will prevent it. You ensure that there is hydration. Your urinary alkalization needs to be done with bicarb infusion, and leucovorin rescue to be done so that the higher levels of methotrexate do not ensue their intracellular effects, causing DNA, causing impaired cellular proliferation and resulting in cell death. The treatment is usually, again, the same. Hydration needs to be increased and increase the leucovorin dose. However, it is the circulating methotrexate which causes AKI, and the only way of removing it is by hemodialysis. However, there is a newer drug, which is glucarbidase. It has been here since 2012, however, super expensive. But the fact of the matter is that it helps in reduction of the dose of the level of methotrexate within about 15 minutes. Next slide. Coming to pemetrexate, which is similar to methotrexate, resulting again from it causes inhibition of dihydrofolate reductase. What it does is once it gets inside the cell, because of its glutamation, it does not have the ability to get out of the cell. Its presence within the cell results in impaired folate metabolism, and hence DNA repair is inhibited and RNA repair is inhibited. Clinical side effects, again, are AKI and proximal tubulopathy. Next slide. Gemcitabine, another notorious drug, which has been there for long, and the most important side effects it causes is TMA. In a series with about 29 patients, biopsy-proven TMA was seen in only 4. However, clinical TMA was seen in almost all patients. So when the patient comes to you, you will be having a TMA diagnosis, however, it might not be present with the biopsy slide. But the preceding signs that you would see that there is worsening hypertension or there is new onset hypertension, all you would try to do is discontinue the drug and give supportive therapy. About 7 patients in one of the series, which had 26 included, had developed ESRD, unfortunately. Next slide. Now, coming to the classification of the patients who develop TMA, among the cancer type drugs type A and type 2, gemcitabine and mitomycin C land up being in the type 1, which are delayed onset have cumulative and dose-related effects, are permanent, irreversible, and high probability of recurrence with reinstitution or re-challenge. And they're notorious to cause chronic kidney disease and then ESRD. In comparison to that, the type 2 drugs, which is the bevacizumab, which is the anti-VEGF inhibitors, they are usually not dose-related. You could have it at the first dose or even after almost 29 months. There is not much evidence to say that with the second re-challenge that you might have the same TMA that you had with the first dose. And usually as soon as you stop the drug, the effects would go away. Next slide. Coming to proteasome inhibitors, we have two of them which are out in the being used, that is bortezomib and carfilzomib, known to cause TMA and ATN. We've had, in the next few slides, I'll tell you about the patients that we have dealt with proteasome inhibited acute kidney injury. Next slide. So we had one of the patients who had instituted proteasome inhibitors for the multiple myeloma that the patient had been diagnosed with. But within a week, the creatinine went up from a 1.8 to 6.4. And you can see the biopsy results of the patient having granulomatous lesions, which are from acute interstitial nephritis that the patient had. Next slide. There was yet another patient who developed TMA from proteasome inhibitors. Usually TMA happens within several months of the bortezomib that the patient had in our case. It could range from 7 months to 10 months. And the only treatment of this is by holding the drug and trying to see if the next proteasome inhibitors, which is carfilzomib, would not be causing TMA. Next slide. Coming to cetuximab, another drug which results in severe magnesium loss, and how it usually acts is it does not allow the EGF receptors to act on the to combine with the EGF, which is responsible for reabsorption of magnesium, resulting in extreme enormous amount of magnesium loss despite several IV infusions of magnesium and oral supplementations. It's almost in 100% of the patients, you'll see a certain amount of low mag or hypocalcemia or hypokalemia. But at least in most of the, at least 50% of the patients, you will see severe hypomagnesemia occurring. Next slide. Now coming to a summary of what the conventional agents usually cause, that is the TMA, toxic ATN, crystalline ATN, and interstitial nephritis. I've summarized it in a very brief way. So we have the mitomycin C and gemcitabine and the anti-angiogenic drugs, which are resulting in the arterial vessel effect causing TMA. The platinum drugs, ifosfamide, pemetrexed, resulting in effects on the proximal tubules. Then you have crystalline deposition because of methotrexate, resulting in crystal deposition, resulting in causing of AKI at this end. Next slide. And I think this is the previous slide deck. However, I had tried to summarize the traditional chemotherapy drugs. There are also, we've got the targeted chemotherapeutic drugs, which are the anti-angiogenic drugs as well, which cause TMA in these patients. Due to time constraints, I wasn't able to go through all the drugs, but thank you very much for a patient listening.
Thank you very much, Dr. Jaya. You have nicely presented everything. Actually, basically, all parts of the kidney is involved in the all type of malignant, anti-malignant drugs. And thing is, day by day, newer drugs are coming up, and it's very difficult to remember the drug's name and how to treat and what are the types of which part really affects. That is very difficult. As you say, definitely magnesium is the definitely you have to see that you say 100% deficiency is there. You have to treat that. Generally, in our day-to-day practice, we usually avoid the dehydration part and hypotension part, and or other nephrotoxic patient is taking or not. And do we have any role of any N-acetylcysteine to prevention of this acute kidney injury in chemotherapy induced? If you are planning for any chemotherapy, can you give N-acetyl? Is there any trial you have? Do you have any idea?
No, so there has been no trial. It's just based on case reports. And that is why I'd mentioned cimetidine has also been tried, because conceptually it will help in reabsorption of the magnesium, not let the toxicity happen. However, the oncologists, so it's as you had mentioned that as we as nephrologists do recognize that hypovolemia, making sure hydration happens, making sure no concomitant nephrotoxic agents are given, so that while the cisplatin is acting, there's another nephrotoxic agent that is there. This is not a perception that the oncologists have. So why this, I believe that our role as nephrologists is to educate the oncologists that these are the drugs that probably for the next cycle, you can hold them, which is, for example, non-steroidals, which are patients such as osteosarcoma, if they are having it and they are getting medications because of that, they are in pain, so they're getting non-steroidals. So if we can avoid the concomitant medications, we'll do a great benefit. But we have not been able to use N-acetylcysteine because there is no evidence to prove that that is definitely going to be helpful. There has been no randomized controlled trial. However, using magnesium infusion during the infusion of cisplatin has known to be able to help in preventing the toxicity that happens during the cisplatin infusion. And that's mainly because it just does not let, there's a lot of antioxidant effects that it has as well. Along with that, it also acts on the same channels. So it just helps in reducing the onslaught at the time of infusion.
Tumor lysis syndrome is the major complication of this all type of malignancy almost. And what about this allopurinol or rasburicase treatment as a prevention of that tumor lysis syndrome?
So once a patient comes in with tumor lysis, we ensure, first of all, as we always do for all our patients, intense hydration, ensure the urine output is about 100 to 200 ml per hour. And as soon as the uric acid starts going up, even before we give it, we've realized that the oncologist already infused rasburicase. The standardized dosing is about 3 milligram that they're giving as one-time dose. Then, of course, they start putting them on allopurinol, and that will be the prevention of having any further uric acid accumulation and uric acid crystallization. So we will always wait for the uric acid results to be back. However, once the tumor lysis markers start showing up that you've started elevation of uric acid, there is hypocalcemia, there is hypophosphatemia, hyperkalemia. We start intense hydration, the patient is immediately admitted. And if requiring a renal replacement therapy, we are pretty aggressive about starting renal replacement therapy. Because even if you start giving them a lot of infusion, the urine output will start going down and they'll be in likelihood of having volume overload.
And what about, for example, if patient developed AKI, is there a role of diuretics and mannitol to prevent or further? Is there oncology associated AKI and normal AKI? Is there any difference?
So we do not, over here, we have not tried to propagate use of mannitol. Yes, the cisplatin unfortunately comes pre-prepared over here along with mannitol. It has been recommended that only when the dose of the of the cisplatin is more than 100 milligram per meter squared, then is the only time when mannitol has proven to be helpful. In lower doses, it would not help much. So I would recommend not using mannitol unless that dose is that high. Using diuretics, of course, for any cases of nephrotox of AKI, if the patient is volume overloaded, yes, you will have to go ahead and use it so that you don't let the patient get intubated. But otherwise, no role of giving diuretics for either tumor lysis or for any other purpose, because here the role is hydration more than volume removal.
And I think there is no questions in the chat box. If any question, then they can mail you.
Yes,
and already bell has rung, so that's why. Thank you very much for your excellent presentation. I thanks the organizers and I thank the Gangaram Hospital for arranging excellent this AKI update. Thank you very much. Over to the organizers.
Thank you very much.
Thank you, sir. Thank you, ma'am. I would request Dr. Sunil Prakash to kindly introduce Dr. Rimda Vanch.
Good evening. It's my pleasure to introduce Dr. Rimda Vanchu, who is Professor of Medicine at Zucker School of Medicine at Northwell. And she has been very ably awarded with Outstanding Medical Services in 2016. And preceding years, she was the Outstanding Intern and Resident in 2003 and 5. So Dr. Vanchu has a very long track record of being right on top. Over to you, Dr. Vanchu, please.
Voice not audible. Not audible again.
On behalf of the organizing committee, we request you to kindly be patient. This is a pre-recorded lecture from Dr. Rimda Vanchu, so we're trying to play it back again. Thank you very much for your cooperation.
So, good morning, everyone. I will be talking about immune checkpoint inhibitors and acute kidney injury, an update. Just to state, I have nothing to disclose. And my objectives in this presentation are to go over the AKI with CTLA-4 inhibitors as well as the PD-1, PD-L1 inhibitors, to go over glomerular diseases that are seen with immune checkpoint inhibitors, as well as the use of immunotherapy in the kidney transplant as well as the dialysis patient. So what is immunotherapy? Immunotherapy differs from traditional chemotherapy in that it targets your immune system, which in turn attacks the tumor. And just a basic sort of 101 slide on how these drugs work. As you can see, you have a T cell and an antigen presenting cell in front. The first step always involves antigen recognition, where the antigen is presented in association with the class 2 molecule and is recognized by the T cell receptor. Once this interaction happens, there is what is termed as the co-stimulatory signal, where the CD28 on the T cell binds with the CD80-86 on the antigen-presenting cell. And when this signal occurs, there is activation of the T cell. However, in order to prevent this unrestrained activation of the T cell, all of us have certain checkpoints in place which sort of inhibit the unrestrained activation of the T cell. And these include that takes place, the T cell actually is inhibited and is not able to proliferate or get activated. Similarly, the PD-1, when it binds to the PD-L1, it essentially leads to the same thing, which is inactivation of the T cell. So here you have a T cell along with an antigen presenting cell, and you have a CTLA-4 receptor antibody, which will bind to the CTLA-4 protein on the T cell and inhibit the inhibitory signal that's happening. So what happens with this is that the T cell actually ends up remaining activated. And similarly, this is the PD-1 and the PD-L1 inhibitor. Once these inhibitors bind to these receptors, the T cell is no longer inhibited and in turn remains activated and can attack the tumor more efficiently. This is just a slide showing the various CTLA-4 inhibitors as well as the PD-1 and the PD-L1 inhibitors that are currently in use. And you can see the indications. It really varies. Lots of cancers that are being treated. And I think that as time goes on, we'll only see more and more cancers wherein these drugs will be used. And about 50% of patients that are on these drugs will develop side effects as a result of the basic mechanism, which is, activation of the immune system. So you end up having various organs being involved. So you can have thyroiditis, you can have pneumonitis, colitis, hepatitis. So it can pretty much affect all parts of your body. And this is just to show the AKI grading, the CTCAE, as well as the KDIGO guidelines, classifying stage 1, stage 2, and stage 3, which we all know. So I'm going to start off with the first case just to give you an idea about how these drugs work. So you have a 69-year-old patient with a history of hypertension, GERD, who's been on a PPI or proton pump inhibitor for several years, is now diagnosed with non-small cell lung cancer. She started on treatment with IV pembrolizumab, which is a PD-1 inhibitor, and 3 months later is noted to have acute kidney injury with a rise in serum creatinine from 1 to 2. You decide to biopsy this kidney. What will the biopsy show? Will it be acute tubular injury? Will it be acute interstitial nephritis? Will it be hypertensive nephrosclerosis, or will it be thrombotic microangiopathy? So just to go over the incidence of the AKI with these drugs, in the phase 2 and 3 trials, the incidence was noted to be about 2.2%. Grade 3 and 4, obviously lesser at about 0.6. If you are on a combination therapy, which is if you are on a CTLA-4 along with PD-1, the incidence of AKI does go up. It's about, close to 5%. This is a single center study from MGH, wherein they looked at 1,000 patients with normal kidney function who received immune checkpoint inhibitors and to try to figure what was the frequency of the AKI. And what they found was that AKI was reported in close to 17% of the patients who were on these drugs, but sustained AKI was more like 8%. However, if you actually try to see whether it was the immune checkpoints that was causing the AKI, the incidence was lower at 3%. Just keep in mind, a lot of patients will have AKI, which could be unrelated. It could be because they are dehydrated or they're on a nephrotoxic medication. So this study showed that in a single center, the incidence was 3%, and the use of PPIs was considered or was served as a risk factor for developing AKI. And if you look at studies from around the world, Spain, Canada, they will be higher numbers reported, close to 15 to 16%. However, keep in mind the incidence which is truly related to immune checkpoint inhibitor is lower, about 3 to 5%. And this is the largest study that has been published. It was published in 2019. Retrospective multi-center study had about 138 patients with immune checkpoint inhibitors, and they actually ended up biopsying close to half these patients, and AIN was the most common diagnosis. So 93% of patients that were biopsied had interstitial nephritis. The time to develop this was a little bit late. It was about median of 14 weeks. And most of these patients actually did well. Close to 85% of patients had remission ranging from complete to partial, and only about 15 actually had no response. The risk factors associated was a lower GFR, use of PPIs, as well as combination immune checkpoint and combination therapy. So if you look at the various studies that have been published, the risk factors for developing AKI with immune checkpoint inhibitors is GFR less than 30, use of proton pump inhibitor. If you're on a combination immunotherapy, so you're on CTLA-4 along with PD-1, you are at a higher risk to develop AKI. And if you have a patient who develops, dermatitis or colitis and now has a rising creatinine, the chances are the patient actually has interstitial nephritis also. And there was this one study which showed that hypertension was also a risk factor. However, that hasn't panned out in other studies. And just to show that it's not only AIN, but ATN has also been reported. And this is just a slide showing that it's very difficult to figure out, just based on clinical presentation, whether a patient has interstitial nephritis or has ATN. This was a study of 15 patients showing very similar findings in terms of the creatinine, in terms of the urine analysis, and they had two different pathological diagnoses. So the diagnosis is not easy clinically, and kidney biopsy is necessary in a lot of cases. And this is just sort of a slide summarizing the mechanisms that are responsible for mediating AKI. The first is that these drugs can lead to autoantibody formation, which in turn can target the kidney and lead to AKI. The second is that the activated T cells now go on to attack the off-target tissues like the kidney and mediate interstitial nephritis. Or you can have a drug-specific latent T cell, which in turn now gets reactivated when you use these drugs. And the third mechanism is that perhaps the inflammatory cytokines that are associated with these drugs will actually mediate the kidney injury. The management, I just would like to say, is that, high quality evidence is lacking. Recommendations are primarily based on expert consensus, and it's limited to case reports, case series. In terms of management, obviously it's important that you hold the drug. And depending on the degree of the AKI, one can decide whether you should hold the drug temporarily or permanently. And I'll talk about that a little bit later, but essentially administer steroids. And if you have grade 2 toxicity, perhaps you could use 0.5 to 1 mg per kg of prednisone. And if you have actually, higher levels of acute kidney injury, you could make a case for using higher doses of steroids, 1 to 2 mg per kg per day. The tapering of the steroids should be done over a course of at least 4 to 6 weeks. And if you have a patient who doesn't respond just to steroids, you might want to consider additional immunosuppression, such as mycophenolate. And this is just to show that treatment matters. If you actually treat these patients with steroids, their odds ratio of complete recovery are much higher. And why does that matter? Because renal recovery is associated with a better survival. This was shown again in the paper that was published in JASN. Patients who recovered did better. And this was another paper which showed essentially the same thing. If you had AKI, you did worse in terms of overall survival. So back to our patient. Yes, the biopsy was consistent with interstitial nephritis. We treated them with steroids, and the AKI resolved and the creatinine was back to baseline. And now the oncologist said, well, because the immunotherapy was working so well and because the creatinine is down, I would like to restart the immunotherapy. So what do? Do you say no? Do you say, okay, we can try re-challenging this patient and watch the patient closely, or do you now keep the patient on low-dose steroids and restart the immunotherapy? So what is the data on re-challenge? So there have been studies that have been published looking at exactly this, that, what is the percentage of patients that will actually redevelop AKI when they're re-challenged with immunotherapy. And the risk is about 19 to 25%. So not everybody will have a recurrence of AKI. However, there will be patients between 19 to 25 that will develop recurrence of AKI. So just to know that it doesn't happen universally, but it does happen frequently, and it's manageable. A lot of these patients, if they're retreated with steroids, will actually have recovery of kidney function. The decision is really based on risk-reward ratio, and if you have a really severe immune-related adverse event, perhaps it's best to avoid these drugs. However, in AKI, you can retry. So we did start immunotherapy. We did not have them on steroids, and so far the patient is doing very well. What else can be used? Mycophenolate has been used. Infliximab has been used. Rituximab, again, only small numbers, case reports, nothing which is, large patient population. But this has been used at least with some response. What about other diseases? So we published this in KI reports, where we tried to look at the glomerular diseases that have been reported with the use of immune checkpoint inhibitor. And actually, we found that the most common glomerular disease is pauci-immune glomerular nephritis, along with renal vasculitis, followed by podocytopathies, followed by C3GN. Again, these are small numbers. Only 45 cases have been reported so far, but they have, and this is the pathology. And most of these patients will recover from, AKI. However, in our study, we found that 19% of these patients were dialysis dependent and 34% died. But, keep in mind, it's a systematic review. We looked at whatever has been reported, and the numbers are small. So the most common glomerular pathology, you can divide them into nephrotic and nephritic. And as I mentioned, nephrotic is podocytopathies, amyloid, and nephritic, as you can see, pauci-immune vasculitis, C3GN, IgA. A lot of these pathologies have been reported. So coming towards suppression with cyclosporin, MMF, and prednisone, she now has metastatic cancer, and the oncologist would like to use a PD-1 inhibitor. What is the best strategy to use in this patient? So do you stop all the anti-rejection medications and start the patient on PD-1 and steroids? Do you decrease the anti-rejection medications and start? Or do you change your calcineurin to mTOR inhibitors, stop the MMF, and do a mini pulse of steroids? And just to, a few things, these drugs, later on the study showed that the use of PD-1 inhibitors was associated with a higher risk of rejection. But again, no study has tested the clinical efficacy of immune checkpoint inhibitors in transplant patients. This was a patient that was from our center. It was published in the NEJM, wherein he had metastatic cancer, required PD-1 inhibitor, and was a transplant patient. And there was some modulation of immunosuppression done, wherein the patient's cell set was stopped. He was started on a steroid taper, and the cyclosporin was changed to sirolimus. And as you can see, this is the second PET scan shows how the patient did beautifully and completely remitted from a cancer standpoint, and also was able to maintain his kidney transplant. And we actually looked at this and published this last year. This was a multi-center study done on kidney transplant recipients who received immune checkpoint inhibitor. There was rejection seen in 42% of the cases. The rejection happened early, as opposed to the interstitial nephritis that you see, which happens over like 12 to 14 weeks. This happens within the first 3 weeks. And if you actually if you reject, 65% of these patients will lose their kidney. And in terms of efficacy, the response was 36% in the squamous cell cancer, and melanoma was about 40%, and essentially showing the same thing that I just told you, that the AKI happens frequently within the first 3 weeks. And when we try to look at the sort of immunosuppression changes that took place in these patients, they were varied. There was patients that had the calcineurin stopped. There were patients who had the anti-metabolites stopped. There was no sort of consistency because really there are no guidelines. And then there were patients who were on mTOR inhibitors. And what at least the study we showed that mTOR inhibitor use was a lesser rejection. And this is just showing that even though these patients have a high incidence of rejection, they actually do well from a survival standpoint. This is the squamous cell cancer subgroup. And if you look at the melanoma group, there was really no, at least not in this study, we couldn't really show any improvement in survival. So just to keep in mind that immune checkpoint is associated with a high risk of rejection, which leads to a high graft loss. If you use a higher number of immunosuppressants and if you use mTOR inhibitors, it's associated with a lower risk of rejection. And at least in our study, we showed that immune checkpoint inhibitors in the group with squamous cell cancer did achieve a robust overall response rate and improved survival compared to the non-immune checkpoint group. But again, this is a small study, observational. So you have to, take it with keeping these limitations in mind. And this is a study that we published about the use of immune checkpoint inhibitors in dialysis patients. And what we found was that really the number of adverse events in dialysis patients is pretty comparable to what is seen in patients with normal kidney function. So there's really no reason that we should withhold these drugs in dialysis patients. And not only do they not have as many adverse events, in terms of patient outcome and in terms of remission of cancer, they do pretty well also. So again, we think, what I've just gone through, AIN as being the most common pathology that is seen, the glomerular diseases that are associated with the use of these drugs, that rejection is not uncommon, and that we can use these drugs safely in dialysis patients. And thank you. This is my email. I will not be there for the question and answer session. However, please feel free to email me with any of your questions, and I will be more than happy to answer them. Thank you.
Thank you, Dr. Vachu, for a very informative talk. And what I would say is, since the questions, neither there are questions in the chat box, neither Dr. By giving checkpoint inhibitors, now we are making cancer a chronic illness, just like diabetes and management of hypertension. So it's a big achievement. Earlier, if somebody had a cancer as bad as solid organ cancers, death was about a year or some time away. So with the help of these, we are making them chronic illnesses, which means the survivals have increased significantly. And how do we suspect immune checkpoint inhibitor toxicity? To my mind, we should remember that they will be subacute. They would come with something like subnephrotic proteinuria or sterile pyuria, and you will have non-renal manifestations which are fairly common, like thyroiditis and colitis is very common in these patients. We should keep an eye. And I would re-emphasize the point that to mitigate the ICI toxicity, the other insults should be avoided, like especially pantoprazole and proton pump inhibitors should be absolutely avoided because they act as haptens to trigger the response. And obviously, we want to have win-win situations in transplants also. There would be problems. So in that situation, favoring the immunosuppression. But having said that, if we have to give these drugs to save the life, that will have the priority and patient may or may not return to dialysis. So with that, I will give back the mic to the organizers. Thank you.
Thank you, sir. Let me move to our third session. What have we learned in AKI? For this, I would like to invite our chairperson, Dr. Jitendra Kumar, Chairman, Renal Science and Kidney Transplant, Accord Super Speciality Hospital, Faridabad. Dr. Rupesh Raina, he specialized in adult and pediatric kidney disease and hypertension, Associate Professor of Medicine, Director of Research, Akron Nephrology Associate, Cleveland Clinic, Ohio. Dr. Urmila Anand, Senior Consultant and HOD Nephrology, Yashoda Hospital, Sikandrabad. Now I request Dr. Jitendra Kumar to kindly introduce Professor Narayan Prasad.
Hello. Hi, good evening, everyone. Dr. Narayan has been my batchmate right since MBBS. We have been MBBS, MD and DM batchmates. But most important, currently he is Professor and HOD of Department of Nephrology, Sanjay Gandhi Postgraduate Institute of Medical Science. He has many notable achievements, and most important being Secretary, Indian Society of Nephrology. He has been former Secretary of Indian Society of Organ Transplant. Not only this, he has been Deputy Chair of South Asia Regional Board of International Society of Nephrology. He is Council Member of ISN and is also member for ISN ANA and India Committee. So he has a very nice CV, but most important, he has a long list of national and international publications, and most of his work has been original one, touching basic science as well as clinical nephrology. So this will be really great to hear from Narayan Prasad regarding acute kidney injury in elderly, and we all know that elderly is the most vulnerable population as far as AKI is concerned, and there is a lot many challenges, not only in diagnosis but also in management of such patients. So over to my co-chair people, and if they are not available, then Narayan Prasad, please go ahead with your talk, please.
Am I audible?
You are audible, please go ahead.
At the outset, first of all, I would like to thank my dear friend, Dr. Jitendra, for this lovely introduction. And before that, I would like to thank Dr. Binand Bhargava and the team of Sir Gangaram Hospital for this opportunity to make me the part of this excellent CME that I have enjoyed for last 3-4 hours now. And I hope that I will justify this topic of acute kidney injury in the elderly population. So why acute kidney injury in the elderly becomes a separate topic? When you look at the literature, it appears that over the last 25 years, the mean age of the acute kidney injury increased of more than 60 years. There is a approximately 3 to 8-fold progressive age-dependent increase in the community-acquired acute kidney injury, and in more than 70 years, a 3.5-fold higher incidence of AKI. One of the Madrid study of the 9-year prospective follow-up has shown average age of the AKI in large European cohort was 76 years, and on the top, when you can see when there is acute on chronic kidney disease or acute on chronic renal failure, the mean age goes further up to 80 years. And they have, those who have acute on chronic renal failure, had usually adverse outcomes. Here you can see this is the USA data where they have compared dialysis requiring acute kidney injury. You can see as with each increase in the 20 years of the age, there is significant increase over these 9 years of the follow, 10 years of the follow-up. Every 20 years increase in the age group, there was higher incidence of dialysis requiring AKI. So why these elderly populations are so much vulnerable for acute kidney injury? We know from our MBBS days that after 40 years of the age, usually the GFR declines. And here we can see the slope of the GFR declines goes from goes from minus 0.3 to minus 3.25 with each decade increase in the age, and the slope go further down and down after 40 years of the age. So that makes this patient vulnerable for increasing serum creatinine early and making them vulnerable for acute kidney injury also. But most of the times you will see even in the elderly had a normal serum creatinine value or normal GFR, and that is compensatory effect, that the single nephron GFR remains stable, and usually despite having this increasing or advancing age, they have a stable urinary albumin excretion. So at the same time, you can also see there is some tubular functional change which is related with the age. They have a failure to conserve sodium salt deprivation. They have pre-renal AKI, very common. Renal tubular acidosis, type 4 particularly associated with hyperkalemia is very common. Maximal concentrated capacity of the kidney go down, and that results into the nocturia, dehydration, and hypernatremia. And maximal diluting capacity also go down, and that results to hyponatremia whenever there is too much of the challenge of fluid is given early. Simultaneously, there is changes in the renal vascular function. You can see increased renal sympathetic tone, decreased nitric oxide productions, and both these, when you have the decreased prostaglandin and a decrease in the nitric oxide productions, you have the afferent arterial vasoconstriction, low flow to the Glome's bed, and there will be reduced GFR. Other endocrinal changes also happens at the same time. Level of EPO, erythropoietin, which is very important to maintain our RBCs level, will slightly increase with the age. Lower level of calcitriol are usually observed with the aging, and one of the study has shown if you are replacing the calcitriol in time in osteoporotic patients, they can prevent the fracture by 50%. Insulin clearance declines and insulin resistance increases, so it produces the hyperinsulinemia kind of things, and that is one of the reasons of the metabolic syndromes that we all understand. So the patients are vulnerable from many points. So just to apprise that, you must remember by the rule of the 10, renal mass declines by 10% per decade. Number of functional nephrons also decreases. Renal cortical thickness decreases by 10% per decade. And renal blood flow decreases by approximately 10% per decade. So what we can see here, this we can just remember, for particularly for the postgraduate students, this is the rule of the 10 where everything decreases by 10% per decade. So what is the molecular mechanism behind that this is happening? It has been observed very carefully that there is increase in the activation of renin-angiotensin system. It is aging is a stage of chronic inflammation. Anti-inflammatory cytokines go down, IL-10 go down, and other pro-inflammatory cytokines go up. That is decreased clotho and decreased PPAR gamma activity. Both makes them very vulnerable for the oxidative stress-related injury. We all understand clotho is related with the aging. Our increased oxidative stress and mitochondrial dysfunction has been seen, vascular damage I have already told you. And there is telomere shortening. Telomere shortening is a very important upcoming point of discussion in many of the studies, which shows that probably DNA repairs becomes defective with the aging. So that all important molecular mechanisms is there that is associated with the aging. And in addition to that, the patient have multiple comorbid conditions, high prevalence of the CKD on the baseline, 38% of the CKD patient is aging more than 65 years. Polypharmacy, patients are on multiple drugs, particularly the cardiovascular drugs, some painkillers that all are associated with high incidence of AKI. Conventionally, we all understand acute kidney injury are pre-renal, renal, and post-renal. Approximately in elderly, 60 to 80% are caused because of the pre-renal causes, 10 to 15% because of the renal causes, and 5 to 10% post-renal causes. Post-renal causes in the elderly are sometimes very peculiar. Enlarged prostate after 50 years is very common. You can see prostate leading to obstructive uropathy is not uncommon to see in the clinical practice. I am not spending time on these slides because everyone is aware about this fact. Approximately 10 to 20% patients you will look into it. They have the history of the nephrotoxic drugs, recent use of the nephrotoxic drugs, particularly in the elderly AKI. NSAID, AC inhibited angiotensin receptor blockers, spironolactones, aminoglycoside, and some of the high-role medicines coming up as a cause of the acute interstitial nephritis that we all have observed. Everyone might be experiencing in their day-to-day practice. So all these drugs, you must have the one checkpoint for all these things, whether these are the culprit in these patients, so that we can omit at the time. These drugs can be omitted from their prescriptions when you are making the diagnosis of AKI in the elderly patient. The diagnostic dilemma is always there. So what is important? History and physical examination. That for any clinician is very important to see renal and postrenal causes. A thorough review of medications that I have already pointed out. You can see for the urine output, signs and symptoms. Ultrasonogram, urine analysis is very critical because this is something, even the patients, elderly patients are very prone for developing vasculitis and RPGN kind of presentation. Dysmorphic RBC and RBC cast shows there must be some glomerular disease. So consider them for the biopsy. If pigmented granular cast is there, you can think of there might be the severe acute tubular necrosis. If urinary WBC is showing eosinophils predominance, that indicates that patient might have the interstitial nephritis. So urine examination gives you many times great hint about the diagnosis. Urine electrolytes is important. Low urinary sodium, fractional excretion of the sodium of less than 1%, and increased urinary osmolality, pre-renal causes. Get it from the MBBS days. But caveat always remains, particularly in the elderly, because their water conserving ability, urinary concentrating mechanism is impaired, and many times the patient are on diuretics, so it may alters. So what could be the alternatives? Your low fractional excretion of the urea of less than 20% indirectly may hint that there might be some pre-renal etiology. So coming to the misleading serum creatinine. Serum creatinine value is many times misleading in making the diagnosis of the AKI. The serum creatinine value of 1 milligram in 45 kilogram 80 years old woman may represent significantly impaired GFR, while the same value in 25-year-old 70 kilogram man would reflect the normal kidney function. Why this happens? Serum creatinine value depends on the creatinine generation, removal rate, and volume of distribution. And elderly patients are may have the very low muscle mass, and here when the creatinine value within the normal range might be indicating that probably the patient has significantly impaired GFR. So newer biomarker might be helpful. What newer biomarker? NGAL, kidney injury molecules, and interleukin-18 might be more useful in such conditions that may indicate probably. And you might have the regression equations, that eGFR calculation, which considers the age and body weight, everything in consideration, and that might be more useful than your serum creatinine value in making the diagnosis. So prevention and treatment in the elderly, coming to this part. So preventive strategy, identify high-risk clinical settings. That if the patient has the pre-existing CKD, cardiac failure, liver disease, patient is malnourished, hypovolemia, that we should look for. Avoid nephrotoxic inserts, contrast-induced nephropathy. Abstain from contrast using, particularly iodinated contrast. So iodine-based contrast should be avoided. Keep optimal hemodynamics during the patient's during the treatment of hypertension. When you avoid using diuretics too much of many times NSAID and AC inhibitors. If the patient is on these drugs and likely that the patient have AKI, then we should stop this. So prevent sepsis development by timely and effective antimicrobial therapy. It is well known that if you are using antimicrobial antibiotic within 1 hour of the onset of the sepsis or infection, you always have the better outcome than using this late. So coming to the management part, fluid balance is always, we have heard for the last 3-4 hours, fluid balance always comes the first part in preventing or treating the patients of the acute kidney injury.
And one of the slides I've seen today, almost 3,000 patients die because of the thirst in the hospital every month in UK. You can think of what might be happening in India, particularly during the COVID situation, where the thirst is very difficult for the elderly persons to move and drink water. So that is the first important thing. Then etiology aspect, a specific preventive strategy should be there always in the mind. Radio contrast exposure, I have already told you. If there is exposure, intravenous hydration with the saline, sodium bicarbonate and acetylcysteine can be given. Aminoglycoside exposure, once daily dosing with drug level monitoring would be better than multiple dosing. Tumor lysis syndrome, intravenous hydration, urinary alkalinization, allopurinol that we have already heard before me. Rhabdomyolysis, intravenous hydration and urinary alkalization, acyclovir and methotrexate. Again, the hydration, amphotericin be used, try to do liposomal formulations rather than the conventional amphotericin. Hemodynamic support, that is one of the important. Fluid resuscitation, many times confusion comes colloid versus crystalloid. This crystal study, a multi-center randomized controlled trial recently published, has shown no difference in RRT and mortality. Physiologic balanced solution versus normal saline solution. So it has been observed physiologically balanced solution has lower incidence of AKI and lower rates of the requirement of renal replacement therapy. One study has shown what should be the optimal mean arterial blood pressure in this group of the patients. Mean arterial blood pressure of 65 to 70 versus higher goal of 80 to 85 has shown there was no difference in the mortality. So a standard teaching of keeping the mean arterial blood pressure at 70 in this patient should be the standard of the care. Additional therapy for AKI, electrolyte balance, sodium, potassium, magnesium, calcium, diuretics should be avoided. It should not be used to treat, only to treat and use this to balance the fluid. Nutrition, adequate nutrition should be there. And then always comes, some of the patients becomes the dialysis dependent. So guideline for the shared decision making, whether these patients are ideal candidates for giving the dialysis. Consider foregoing dialysis for AKI, CKD, and ESRD patients who have very, very poor prognosis. So it is possible that, and this would be the conscious decision with the family members in confidence and your internist and your intensivist all in confidence. Agents tested selected trials. Selected trials, I'm going, what are the different trials going on for the treatment, like alkaline phosphatase, L-carnitine, remote ischemic preconditioning, P53 targeted siRNA, post-cardiac surgery in AKI. These are the trials going on. Extracorporeal devices, dialysis requiring AKI, vitamin D in hospitalized AKI, uremic toxin absorption and toxifying in hospital-acquired AKI. These are some of the trials going on at present. So coming to the outcome, when we look at the 80 years versus less than 80 years, what we can see, circulatory insult is more than 80 years, septic shock in more in less than 80 years. ICU admission, any dialysis are usually less than 80 years have more ICU admission, more dialysis. In hospital mortality is more than 80 years, in more than 80 years of the patient. What we can see here, the effect of the mortality is there with the gender, AKI stage, comorbidity, and pre-existing renal function, but there is no effect of the age. So this paper shows that, this has just come, this paper has shown that probably you should not avoid treating these patients of the more than 80 years also. And as the stage of the AKI go up, mortality go up to in the stage 3 80 years. We should not forget about the COVID-19 and AKI in the elderly. This is the paper we have shown 13% of the elderly develop AKI and 14% die off. And you have the mortality with the AKI is very high. And one study has shown COVID-19 and AKI have 80% odds ratio of 80 as compared to COVID-19 without AKI. So recovery of renal function is always very important. They have full data of the meta-analysis has shown there is 20% higher chance of the less recovery in patients who have elderly AKI. And again, it is independent of what we can see. CRRT, intermittent hemodialysis, does not affect outcome. What affects outcome? at the time of the discharge, persisting renal dysfunction and the baseline serum creatinine are important in showing the signs whether this patient is likely to recover or would have the residual renal damage in the future. So take home message from this presentation: elderly patient at higher risk of development of AKI, a specific hemodynamic, metabolic, and molecular changes lead to increased susceptibility to injury. Certain causes of AKI are more common in the elderly. Multiple etiologies are often operative in the development of AKI. So outlook for renal recovery is likely impaired in the elderly patient. Almost pooled data is showing 28% of the patient might have residual damage in the future. So thank you, everyone. Thank you for your time and attention. Thank you.
Okay, great talk, Narayan. And it was so lucid and so easy to understand that we don't have any questions in the chat box. But I would like to point out that many of these elderly people, they keep their prostatism and obstructive symptoms. They just hide their symptoms because they think that this is part of their elderlyhood. So we should be very particular about that history. And number two, in country like India, lot many people will be also having these alternative medicines, which we have to especially take from the history. My question from you is that when this comes to calculating GFR, so knowing the limitations which we have just described, what you will suggest how to follow the GFR in this elderly population?
Yeah, definitely, Dr. Jitendra, this is one area where we should always think of. All equations are not equally good. You might have MDRD equation, CKD EPI equations, but CKD EPI is looking relatively better than other equations because they consider for now ethnicity is being removed from the CKD EPI. But considering the age, weight, and everything, it appears that eGFR calculation at least would be better than the serum creatinine value. So that is the one thing. But at the same time, when you look at the eGFR and based on the 13% of the population of the USA in one of the study has shown that fall into the CKD stage, despite being their renal function was normal and they were elderly. So looking at our CKD definitions of the GFR of, we are taking the cutoff of the 60 ml of the GFR, but elderly population, many elderly population might have the 50 ml of the GFR, 45 ml of the GFR with a normal renal function. So that actually overestimates that kind of the equation-based definition of the CKD and AKI. So that will remain problem, and that is the dilemma here in making the definition of AKI also in the elderly, and even the CKD definition for the elderly, that also needs to be revised. And people are working on this. I think there might be some solution in the near future.
Now, maybe that you may have some SGPGI equation kind of thing. So,
we are recently developing on the 800 patients in the normal populations. We have collected the data, and are likely that we might be able to come with some Indian CKD EPI equation.
So thank you, Narayan, for that great talk. And over to the next talk.
Thank you. Thank you, everyone. Thank you.
Thank you, sir. Now I request Dr. Rupesh Raina to kindly introduce Dr. Siddharth Sethi.
Well, good morning, my time. Good afternoon or good evening, your time. This is a tough task to introduce Siddharth. I know Siddharth for almost going back to 9 years, almost going to be 10 years when I was introduced to Siddharth by Dr. Vijay Kher. Siddharth, I will just say in one line, is an icon of the pediatric AKI. And Siddharth has been trained here in the US through the ISN fellowship. He's from All Indian. So I don't think anybody in pediatric worlds, both international and national level, need any introduction for Siddharth. But a couple of things I really want to bring into the light for introduction for Siddharth is Siddharth has been working as a co-director with us in the PCRRT Foundation. He's been involved in the IPNA education and ISN. And he has done various breakthrough researches in the pediatric AKI, including the PCRRT guidelines, and talking more about AKI renal replacement therapy. And we have been recently has been a pioneer in publication of our COVID-19 talk. With that, it's my pleasure and honor because when Dr. Vinant Bhargava asked me to introduce Siddharth, I said it's an honor to listen, Siddharth. And I also
Your voice is not audible.
Can you hear me now?
Yes, sir.
Okay. So before I start, I would like to thank Dr. Bhargav and the Sir Gangaram Hospital team for inviting me to talk about our passion, which is on critical care pediatric nephrology. So over the next few minutes, I'll be sharing what has changed in the last decade on the new information about pediatric AKI. Now, way back in 2007, when the Texas Children's Hospital, they modified the adult rifle criteria into the pediatric rifle criteria by Dr. Erican. It was a breakthrough study. And in this study, they showed that acute kidney injury occurs early in the ICU. Even the mortality also occurs early in the first 7 days of the pediatric ICU stay. And as all of us know, even in children now, acute kidney injury is an independent predictor of mortality, regardless of the severity of illness. Now, the pediatric rifle criteria is slightly different from the KDIGO criteria. However, since KDIGO is uniformly used all across the world, we all have started using KDIGO classification even in the pediatric age group. Now, how do we compare the definitions, whether it's the ECIN or the KDIGO or the pediatric rifle criteria? This is a study from Stanford, the largest study done till date on pediatric data, where they compared the P rifle to ECIN to KDIGO. And they found that if you look closely here, you'll find that P rifle tends to find more of early stage 1 AKIs as compared to the other criteria. However, whatever definition you use, whether it's KDIGO or pediatric rifle, all of them correlate well with mortality. All of them correlate well with the length of stay in the ICU. And all of them have a very good interstage discrimination, by which I mean AKI stage 3 does worse than 2, 2 does worse than 1. Pediatric rifle is a very sensitive criteria. It diagnoses more stage 1 cases. ECIN is more selective, a research-based criteria, which we used to use around 10 years back. However, since KDIGO is a uniform criteria, and as pediatricians, our patients go on to adults, we tend to use more KDIGO now for our research. Now, according to the AKI advisory group by the American Society of Nephrology, they looked at the 24 studies looking at all the pediatric data, and they showed that acute kidney injury is not uncommon. In adults, 1 in every 5, and in children, 1 in every 3 during the hospital stay gets an AKI. Now, what are the demographic comparisons over the last decade in children? Now, if we look at the developing world, for example, in Kenya, the most common causes of AKI are still infections and septicemia. However, in the developed world, in the States, this is a study from States, where they found that the most common cause is post-cardiac surgery, post-bone marrow transplantation, and so on. However, in India, it's still acute tubular necrosis, secondary to infections, AGN, and hemolytic uremic syndrome. This slide shows the etiology of AKI in India over the last 3 decades. And as you can see now, this blue is diarrhea. Diarrhea-related acute tubular necrosis is falling. Hemolytic uremic syndrome is almost the same fraction which we used to say way back in 1980s. And of course, infection-associated ATN is the most common. GNs are a minor proportion in older children, followed by obstructive uropathies. Now, there's a need to understand the cause of AKI in children, especially in our region. And I'm happy to share with you that now we have collaborated as PCRRT Iconic Foundation. We have collaborated with all of these countries, the flags which you can see here. And we have initiated almost 2 years back a SARC pediatric AKI database, which we call it as ASPIRE, looking for the risk factors in epidemiology. And I'm sure in the next few years, we'll get back to you on what are the common causes of AKI in our part of the world. Now, as all of us know, the conceptual model of AKI, however, there's a need to understand and find children who are at increased risk before they get AKI. So we need to know who is at risk. And there are elegant studies on children who are sick. This is a study from Texas children. This is a study from Montreal. This is a study from LA, where they show that the incidence of AKI depends on how sick the patient is. If a child is ventilated on inotropes, the risk of AKI is higher as compared to if you look at all the pediatric ICU admissions on the right, you will see that the risk is around 10%. Now, this is the largest on your screen, the AWARE study published in New England Journal, which was a multinational prospective study done over 3 months across multiple nations. And they found that the incidence of AKI in sick children is around 26%. And the incidence of severe AKI is 11% in sick children. And this study again showed that there's a very good interstage discrimination in finding the odds of death. If a child gets 3, he does worse as compared to 2 and 1. It's common post-cardiac surgery. So it's common depending on the complexity of the surgery. So if you have a neonate undergoing a complex cardiac surgery, the risk is almost as high as 60% versus if you look at all the cardiac surgeries. Just one second. So at Medanta, we are very commonly seeing children who undergo bypass, and this is one of our area of interest. Here we looked at almost 200 children who underwent bypass over 1 year, and we found that AKI is almost seen in 10% of our cardiac bypass. And those children who get stage 3, they do worse. In fact, in this study, all 4 children who required dialysis post cardiopulmonary bypass, they died. What are the risk factors? The children who are young, who undergo a complex surgery, who have a prolonged bypass time, prolonged ventilator requirement, who get pump failure, septicemia post bypass, they do worse as compared to children who are older and who have a less complex surgery. Now, it is not just about critically ill children. This is a study from Texas Children's again, where they showed that children who receive aminoglycosides in the wards, they also do worse. Whatever diagnosis, whatever criteria you use, whether you use P-rifle or you use the Akin criteria, the incidence of AKI is high even in the wards in children. And the risk factors are children who receive longer treatment with nephrotoxins, aminoglycosides in the previous month. It's not just about aminoglycosides. The more number of nephrotoxin exposures you give to a child, higher is the chance of AKI. So in this study, they showed more nephrotoxin exposures to a child, higher is the risk of AKI in these children. It's common even in newborns. And this is one of our area of interest. And as you can see, newborns who are extremely low birth weights, very low birth weights, those who undergo birth asphyxia, septicemia, those who require an ECMO, all of them have a very high incidence of AKI. And again, AKI is an independent predictor of mortality in all of these children. Risk factors for acute kidney injury in newborns. I'm sorry for a busy slide because there are multiple factors which cause AKI in newborns, from birth asphyxia to maternal exposure to nephrotoxins, if it requires ventilator, inotropes, and so on. Now, I'm happy to share one of the multinational study in which we were a part of, the AWAKEN trial. The AWAKEN trial was a 3-month retrospective analysis of our NICUs with David Ashkenazi leading that. And there were 4 countries and India was a part of it. And we found that in newborns who receive intravenous fluids for 24 hours. So this was the inclusion criteria. If you have a newborn who receives IV fluids for 24 hours, the risk of AKI is 27%. And if a baby is preterm, more preterm the baby is, this red is AKI, higher is the chance of him getting an AKI. So this was a retrospective analysis from the AWAKEN group. And I'm happy to share with you, thanks to the ISN clinical grant, we are now able to make an Indian neonatal AKI consortium. So what we do is, all across our country, we have 11 centers and we collaborate using the same inclusion criteria of a baby who requires IV fluids for at least 24 hours. And we are looking at what are the causes of AKI outcomes. So we are looking at it prospectively. And This, we call it as the Tinker study now, and the protocol has been published in Frontiers this month, the Indian Iconic Neonatal Kidney Educational Registry. And now, since 2018 now, we have almost 2,200 newborns, and we are still adding. So this is the largest ever prospective database looking on the risk factors of AKI in newborns. And we have all categories of newborns prospectively being enrolled in all the centers. Now, it's also important to risk stratify these children. The renal angina index, which was by Dr. Goldstein and colleagues, they looked at, if you look at the risk, multiply it by the injury, whether he gets AKI on fluid overload, and multiply that, then you are able to find a score. And this score may predict AKI in the next 3 days. So if you look at, this is the slide showing area under the curve of renal angina index. When you define it by a reduction in the creatinine clearance, or you define it by fluid overload, and you look at the area under the curve, the RAI, the renal angina index, does better even than the conventional illness severity score, which we use in children like PRISM. So it does well in predicting AKI. And as a pediatric nephrologist, and I'm thankful to Dr. Raina for leading this, last month we published our STARS neonatal AKI prediction score. So this is a score for newborns. It's a score, a simple score. We looked at almost 700 prospective newborns, and it's a simple score of 10 variables. And if you find a score looking at what is the gestation, the urine output of the baby, creatinine, you are able to predict AKI in the next 3 days of the neonatal ICU stay. And this score, we have even the dashboard is online on our PCRD website. So all of you can just go to the website. If you have a baby, right at admission, if you just put yes or no in all of these 10 variables, you can have an idea whether this baby will have an AKI in the next few days or not. We are right now in process of validating this score in multiple cohorts, and we'll get back to you with multiple publications on the same. Now, looking at the biomarkers, I don't need to talk about biomarkers in this AKI meeting. However, I would like to add that in addition to RAI, if you are able to do just one biomarker, this is a study where they just added a biomarker to RAI, and they found that the area under the curve increases much. So I know we are cost constrained settings. So if you have a risk stratification score, and in these children, you use biomarkers, you may be able to manage these children well. So this is one of the dream slide which we think of. You have a patient who comes to the triage, you do a risk stratification. If the risk stratification score is high, now these are the children or adults, you can subject them to biomarker assessment, and you do your supportive stuff as nephrologists to prevent the complications in these patients, limiting the nephrotoxins, avoiding fluid overload, and considering early RRT. Fluid overload is a very important criteria. And as PCRT Iconic Foundation, this is a very important formula for the fellows. Whenever you have a patient in your ICU, please look at the daily fluid overload. Look at the cumulative fluid overload, because now there are multiple studies. This is a study from the PCRT cohort where they found higher is the fluid overload, higher is the risk of mortality. Even if you forget mortality, if you have a patient who is fluid overload, his ventilation is also impaired. This is a paper which we published in Frontiers, where we showed that patients who die, of course, they die in the early stay of ICU, but even the patients who have high fluid overload, they also do worse in the first 7 days of the ICU stay. So the fluid overload correlates with the oxygenation in these patients, and higher the fluid overload, higher is the correlation with their oxygen requirement in the ICU. So coming now to RRT in these patients, and I would just talk about what is new in RRT in these patients, and we are excited about new devices. We are excited about Aquadex coming up. We are excited about Nidus, a new infant Castle device, which can be used in newborns. And the best and the foremost has been the Carpe Diem. Dr. Rupesh Rana is here as the chair. And Carpe Diem is a device made by Dr. Ronco, And now this device is available all across the world, and in multiple centers in the US, they are using that. So we would be excited to know more about that device once it comes to our nations. As living in a constrained setting, we have done multiple work on SLED, even in children. And I feel that if you don't have CRRT, if you don't have Carpe Diem, I still feel that we can do SLED in sick children. And we published the guidelines on SLED in children with the PCRRT consortium recently. And I would advise all of you to have a look at these guidelines. Now coming to follow-up, and there are multiple studies on follow-up, and this is Dr. Memon's study from Canada, which was the only prospective out of these. Now all these studies show, whatever study you look at, retrospective or prospective, all studies show that children, if they get an AKI, they are at risk of CKD, proteinuria, hypertension, death later in life. Even biomarkers, this is a study from Dr. Devarajan's group, where they showed that even if a patient completely recovers, creatinine is normal, proteinuria is normal, no hypertension, but years after AKI, their urinary biomarkers are still high. So there is something still going on. There's a subclinical inflammation still going on in these patients. Last month, we published in KI reports the long-term renal outcomes of children who have AKI post-bypass. And this was also thanks to the ISN clinical grant, and where again we showed that children who even completely improve, even then their urinary KIM1 and the KIM1 to creatinine ratios are still high, even years after a cardiac surgery. So it's important to follow these children. This is almost my summary slide, and I would like to refer all of you to the PCRRT guidelines, which Dr. Raina has been headed, and there are multiple studies and guidelines which we are in process of, and I'm sure this will help the clinicians managing children with AKI. We cannot, this talk cannot finish without talking about COVID in children. I know we are short in time. However, I would like to share with you that MISC, the multi-systemic inflammatory syndrome in children, is still there even in our country. So even in my ICU right now, till last week, our ICU was full with children with MISC. So we need to understand as nephrologists and pediatric nephrologists that AKI is common in these children. Dr. Rana is looking at the United States, North American data of the VPS and looking at what causes AKI in these children and what are the complications. So I would refer to you all to the PCRRT consensus statement on how to manage children with COVID-19 and AKI, published last year in the Frontiers. And I would also like to take this opportunity to all of you to invite to our next critical care pediatric nephrology meeting, which is focused on newer markers, newer machines, newer risk stratification scores, and a course on point of care ultrasound for children. The website is here. And I thank you once again for inviting me here. Thank you.
Excellent presentation, Dr. Sethi. As I told you before, that I always learn from your presentation. I think we have very few questions, and let me go ahead and have other panelists. If you have any specific questions about the pediatric AKI, I'm happy to take it. I think as Dr. Sethi has summarized, we have really learned a lot during this COVID-19, and we have been really focusing on these extracorporeal adsorption therapy. So Siddharth, I have a question because I wear both adult and pediatric hat, which is kind of tough when you switch from adult to peds. And it's such a nice variety, right? A horizon, you're talking about neonate and Dr. Narayan Prasad ended with elderly. What do you think about the issue with identifying an AKI in pediatrics? It's the same pattern that we have in hypertension. People were denying into it. Do you think, are we doing better job than adult? Or what are the challenges do you face in developing countries with identifying early identification of the AKI and do early goal-directed therapies?
I'm sure you're right that we need to develop more models to identify these children who are at risk. So I think we need to, in a developing world or in our emerging world, I think we need to have more awareness about this to the clinicians using more risk stratification scores. And I'm happy that we made the neonatal risk stratification score so that these children are identified early, because once they go into a severe AKI, they're in for long. So I think, yeah, we need to, first of all, understand the epidemiology more better in the South Asia part of the world, and then work in that direction.
So with that, I have another question. What do you think is the most important marker in pediatric AKI, not in neonate? I'll move on from, because peds is divided into spectrum, with neonate going to be like a little bit adult and then adolescent. What is a good marker? Do you think urine output, any of the urine biomarkers, or urine sediments, or you're talking about fluid overload? What do you think would be an early marker to identify, so we can do a primordial prevention with your slides rather than getting consulted? I always say that in that slide, you consult us between the renal failure and death. We have no room. We are just there. The other thing, it will be a mortality, which is 70% when you go to RRT. So what do you think would be the good armamentarium for the people to look at?
Of course, there are a lot of studies on the urinary biomarkers, and there's a lot of evidence on diagnosing early using the biomarkers. But since we cannot use a panel of biomarkers in every patient who comes to the triage, so I think we need to identify these patients, and only in those patients judiciously use the biomarker panel. Only in those patients, not use, say, a biomarker panel in every patient, because there are no resources for, even in US, I'm sure no one does biomarkers in every patient. But it's important to look at in selected group of patients, along with a clinical assessment of these patients.
Excellent. And I'll just have 30 seconds. I just want to also, if you can give a word of wisdom regarding for the new neonatal devices, anything you want to say with your 20 seconds for questions.
I would just say we need to do what we are good at. So it's not about carpe diem, it's not about NIDARS. Even PD saves lives. So it's okay even if we don't have carpe diem, but I'm sure we do as well using PD in children. So I think the wisdom is we need to do what we are good at. We need to not wait for a CRRT device to save lives. So even PD, and there is no study which says CRRT is better. So of course, we need to do what we are good at.
Excellent. Thank you, Siddharth. Thank you for your insightful talk.
Thank you,
It's
Dr.
very
Rana,
good,
for
at
chairing
least
the session.
wearing the adult hat. It's very important for the adult nephrologist to understand pediatric AKI exists. With that, I will defer it to the moderator.
Thank you, sir. Now I would request Dr. Urmila Anand to kindly introduce Dr. Sylvie Shah.
Good evening. At the very beginning, I'd like to thank Vinant and the team of Sir Gangaram Hospital for giving me this opportunity to introduce Dr. Sylvie Shah. Dr. Sylvie Shah is known to many of us. She has been actually involved in sort of giving talks to us. She has been part of our South Asia Regional BOE meeting. And she is now currently the associate professor. I apologize, she is not the assistant professor anymore. And I would like to congratulate her for her promotion, for being the associate professor of medicine at the Division of Nephrology, University of Cincinnati, Ohio, United States. She has done her fellowship in both nephrology and transplantation, and her expertise is in women's health and cardiovascular health and kidney disease. She'll be talking to us about obstetric AKI. Dr. Sylvie Shah, please.
Thank you, Dr. Urmila Anand, for the wonderful introduction. And I would like to thank Dr. Vinant Bhargav and the panelist, Sir Gangaram Hospital, and the organizing committee for giving me this opportunity. So I would be talking about obstetric AKI. And this is one area where I'm very passionate about: women's health and kidney disease, pregnancy in kidney disease. Since there is not a lot of research on this area, it is under-recognized. So a subject which I'm very passionate about. I have no conflicts of interest. So let's start with the case. I see a 33-year-old female with history of diabetes and lupus nephritis, which is in remission. She sees me in clinic and she wants to have a baby. She has history of preeclampsia in her previous pregnancy. She's currently on lisinopril, labetalol, and vitamin D. And she has the following questions. Her first question is, what is the likelihood of kidney injury in her? Then next, she wonders what are the various causes of kidney injury which she can have during her pregnancy, and what are the risk factors which puts her at, specifically her, at higher risk. She's also worried about the course of her pregnancy, and of course, if she's going to have a live, healthy baby. And also, lastly, she asks me what are the treatment options which are available if she develops a kidney injury. So these are the learning objectives of the presentation. We would be talking about incidence and etiology of acute kidney injury in pregnancy. Next, we would talk about pregnancy risk assessment and counseling. And then we would talk about managing a woman who is pregnant with acute kidney injury. So let's start with the incidence of acute kidney injury. So this was one of the papers which was published by our group, which looked at pregnancy-related acute kidney injury in the United States. So we looked at the nationwide inpatient sample over a course of 10 years. This actually captures all the hospitalizations in the United States. It's a stratified sample of the United States hospitalization. We had around 50 million of pregnancy-related hospitalizations over a course of 10 years. And what we showed was that the incidence of acute kidney injury was 0.08%. So this is a little bit less than other countries, what has been reported in India and China, where it has been ranging around 1.5 to 1.8%. But this was still higher, significantly higher than what has been reported in the previous years. Interestingly, 9% of those required dialysis in our cohort. And we also showed that, these pregnancy-related AKI hospitalizations, which were complicated by dialysis, had a higher mortality of 12% as compared to 3% in pregnancy-related AKI hospitalizations that did not need dialysis. So the other thing which is now reported is that AKI incidence is increasing. And again, this is the data from our study. We looked at the incidence of AKI over a course of 10 years. And what we showed was that the overall incidence was 0.08%, but the incidence was higher to 0.12% in 2015 as compared to 0.04% in 2016. And why the incidence is increasing is, although there is higher awareness, we hypothesize that the reason is there is increase or higher diagnosis of pregnancy-related AKI right now, and also more older women are getting pregnant, and age also puts them at a higher risk of developing AKI. So if we notice in the second B panel, we looked at the incidence of AKI with age. And if we look at the top line, the highest incidence, the highest rates were in older women who were 40 years or older. And there were significantly higher rates, even for women 30 years or more, as compared to less than 30 years, again, indicating that older age puts them at higher risk. Also, history of diabetes is a significant risk factor, if we notice. The incidence of AKI was actually around 1.2% in women who were diabetic, as compared to 0.5% in women who were not diabetic. So both older age and diabetes are risk factors. In addition, ethnicity also plays an important role. Interestingly, women of Asian ethnicity had a lower rates of pregnancy-related AKI as compared to women who were of Native American or Black ethnicity. So next, let's talk about the various causes of AKI. So this the causes of AKI are mostly divided by trimester. The most common cause is hyperemesis gravidarum, which is mostly seen in the first trimester, and also septic abortions. And now, although the incidence of septic abortions is now declining worldwide with better healthcare facilities available, but still these two remain the most common causes. Next is preeclampsia. So after 20 weeks, mostly it's preeclampsia or urinary tract infection. Preeclampsia does contribute to about 15 to 20% of cases of AKI. And HELLP syndrome is another important cause, which is seen in late second or third trimester, along with thrombotic microangiopathies, which can be TTP or acute fatty liver of pregnancy. So acute fatty liver of pregnancy is seen. I had a very actually good a colleague who developed acute fatty liver of pregnancy with her pregnancy of twins, and it can make you really sick. Possibly you may even need a liver transplant. So I think timely diagnosis is very important. Atypical HUS is usually seen in postpartum. So we always should be monitoring kidney function postpartum as well for women who are at high risk. The other thing I would like to point out here is that a lot of these causes in second or third trimester have overlapping features, especially preeclampsia, HELLP syndrome, thrombotic microangiopathies, and lupus nephritis. So therefore, diagnosis is always challenging, and we have to look at the overall clinical picture when we are making a diagnosis of AKI. Lupus nephritis is another important cause, which is seen, and obviously it's recommended that they should be in remission. Like my patient whom I saw in the clinic, she was in remission. Her creatinine was 0.8. She had minimal proteinuria at that time. So they should be in remission when they are deciding to get pregnant. And the other causes include obstructive uropathy, placental abruptio, and use of NSAIDs, which again can put you at risk for AKI. So next are the risk factors. The question which my patient had: what are the risk factors for developing pregnancy-related AKI? And we did see the higher rates, but in our study we looked at the we looked at the adjusted model, adjusting for a type of race, ethnicity, the socioeconomic status, year, and we did notice that diabetes significantly puts you at a higher risk of developing AKI, which is about around 4-fold higher risk. Similarly, history of preeclampsia, which is a well-known risk factor for AKI, gives you a 7-fold higher risk of developing pregnancy-related AKI. Also, I would like to highlight here is age. As we were talking, older age is a significant risk factor, and something we should counsel these women, because nowadays a lot of women are 30 years or older when they get pregnant. So anything above 30, even if you are 30 or more, actually increases the risk by more than 30% of developing pregnancy-related AKI. Another interesting thing which we noticed was that the risk increased over the course of years. So even though we may think, well, we are providing better medical facilities, but the risk of AKI over the years increased. And as you see in 2015, the risk was about 2.2-fold higher. Again, related to the fact that maybe we are they are getting better diagnosed and now, and that's why we are catching these AKI in a timely manner. The other thing is what are the outcomes if you develop pregnancy-related AKI? And the question which my patient had, so pregnancy-related AKI does put you at high risk of adverse outcomes. It is a well-known fact that CKD increases the risk, kidney transplant during pregnancy increases the risk. So even AKI increases the risk. And for maternal outcomes, it can increase the risk of preeclampsia, maternal mortality, cardiovascular events, cesarean sections, placental abruptio. And fetal outcomes, it does increase the risk of preterm births, low birth weights, stillbirths, and perinatal mortality, which is around like 3.5-fold. This is the study which was actually done a few years back at Harvard, and the group, Dr. Tangran and group, looked at if history of recovered AKI increases the risk, increases adverse pregnancy outcomes. And interestingly, they had around 100 patients in their cohort who had recovered AKI. So when they got pregnant, their creatinine was normal, and they compared it to a control group, which you can see in blue bars, which were matched with regards to age, ethnicity, and comorbidities. And what we see is the adjusted risk of preeclampsia was actually higher by 5-fold in these women who had history of recovered AKI. At the same time, the risk of preterm deliveries was 3-fold higher. The risk of NICU admission in neonatal intensive care unit was about 4 times higher, which again could be related to preterm birth, small for gestational age babies. AKI does increase the risk of adverse fetal outcomes. The next is maternal mortality. And this is something which our group looked at, if pregnancy-related AKI increases the risk of maternal mortality. And interestingly, and even shockingly, what we found was when we adjusted it for other covariates, including age, ethnicity, comorbidities, what we showed was that pregnancy-related AKI increases increases the risk by around 13.5-fold. So this is a very high risk of mortality, and this is what we are looking at inpatient mortality when we developed AKI. So I think it's very important when we are seeing these women who develop AKI, we really have to keep in mind that risk of maternal mortality in them is extremely high. And as we talked in our first slide, especially if they're requiring dialysis, the mortality goes much, much higher then, as compared to when they are not needing dialysis. The other thing which has not been reported in literature, but we showed in our study, I think for the first time, was that pregnancy-related AKI increases cardiovascular event risk. Now, our hypothesis was we know that AKI is a risk factor and kidney disease is a risk factor for cardiovascular event. And that's why we wanted to look at if AKI during pregnancy increases the risk of cardiovascular events. And the 3 events which we looked at was acute myocardial infarction, congestive heart failure, and stroke. And what we showed was that the risk was around 20-fold higher for any cardiovascular event, and congestive heart failure again was the risk was overall adjusted risk was 10-fold higher for any cardiovascular event. So what about diagnosis of AKI in pregnancy? So diagnosis of AKI in pregnancy is very challenging, and so it's important that we make a timely diagnosis. Usual baseline creatinine in pregnancy is 0.4 to 0.6. It does go down because there is increase in renal hyperfiltration. So the GFR does go down. The usual baseline is around 0.006. So we have to keep this in mind when we are seeing these patients. We don't really have KDIGO, AK, rifle doesn't really define pregnancy-related AKI. So that's always a challenge. Regarding biopsy, it's always preferred to do biopsy in the first and second trimester, less than 25 weeks, and only do biopsy when we think the treatment can improve maternal and fetal outcomes. Otherwise, early delivery is the key to go if they develop complications of preeclampsia or acute fatty liver of pregnancy. These are some disease-specific treatment of AKI in pregnancy, including hydration, use of plasma exchanges if patients have TTPs, and use of steroids and immunosuppression with glomerulonephritis. And just in brief, we should remember that mycophenolate mofetil is teratogenic and is contraindicated during pregnancy. It is safe to use azathioprine and prednisone. And calcineurin inhibitors are also safe to use in pregnancy, but do need dose elevation. Intensive dialysis does improve pregnancy outcomes, but this study was done for ESRD patients, so we do have to keep that in mind. But if patients with AKI do need dialysis, intensive dialysis is maybe needed, especially to improve fetal outcomes. And this is our role as nephrologists. I think educate them, support them, and then make sure we treat the underlying cause of AKI and provide them a multidisciplinary care, which should involve a neonatologist, a maternal fetal medicine or high-risk obstetrician, and us as nephrologists when we are managing their care. And this is the summary of what I just talked about. And I would like to thank my family, our research team, my mentors from University of Cincinnati, without which this work would not have been possible. This is one of the guest issues which I edited, Women's Health and Kidney Disease, which has some great articles, including information on AKI and pregnancy, if somebody would like to check out. And thank you again for the opportunity.
Thank you, Sylvie. Very nice lecture, and thank you for bringing the insight. Nice to see you in the Zoom world. Sorry, there was the chat. The chat questions are coming a little bit back and forth. So I have some little bit questions which I go retrospective for the previous talk. First of all, nice to hear from Dr. Alawat. I think your question was whether we can use, and that goes to Dr. Narayan Prasad, about using the cystatin C for the elderly patient. And actually, you're right. We are doing that study and looks like the cystatin C is coming along as a good marker, although it's not very biological or completely replace the nuclear biomarkers, but it is kind of very close. And on that end, I also want to add on that we have done the studies on CKID. The adolescent patients that you have from the age 17 till 21, cystatin C is a very good marker for the eGFR. It correlates very similar to the ophthalmic GFR. There was also a question from our friend Britila Eziano. She was asking about a question about serum creatinine and the kids, the neonate with the maternal, that weans off in 48 to 72 hours. And definitely the serum creatinine is not a good marker for the neonates. And it's a challenge looking into the structure. There was another question I missed, which was about a 70-year-old with an eGFR of, with the creatinine of 1, should antibiotic be adjusted? That's a pretty open-ended question, and it's a controversial topic. So I don't know how much I can answer you on that part. That's your decision looking into the other cardiovascular or other modality. Now, Shilvi, I have a question for you, and then I have one question from my side. What are the question is on the Q&A session, this is a very relevant question, is what do you think about the biomarkers for the AKI in the setting of pregnancy?
So there is no biomarker for AKI in pregnancy. And to be very honest, I know there's a lot of research which is being done in biomarkers. Cincinnati Children's is actually the hub of biomarker research. But again, I think diagnosis of AKI in general is very challenging with pregnancy because of serum creatinine and GFR. Also, I think it's based a lot on clinical presentation, and even in practical setting, I think I'm not sure how often we use biomarkers for even diagnosing AKI in general population. I haven't personally used till now. So I know that a lot of research is being done, and there's a lot of great biomarkers, but I think when we are seeing patients, and we can ask other panelists, like in general, I just came off service and I didn't even use a single biomarker to diagnose AKI. So from a practical standpoint, again, how much utility we have from a practical standpoint is another question. But there are no biomarkers for AKI in pregnancy for now.
I tell the fellows the same thing. When I started in 2001, there was serum creatinine. In 2021, we only have serum creatinine to look for.
Yeah, I mean, that's what it is, because, and my other question is, even if your serum biomarker is elevated, what are you going to do about it? It's a very good for, maybe not prognosis, but you're not going to give them fluids. In general, it's all based on clinical status, right? It's if your creatinine is normal, you're not going to do anything about it. So that's another thing. So it's good for prognosis, and I think it's good for awareness. But
it's a tough area. Being a med-peds nephrologist, I always get dumped and given the maternal fetal consults and and the OB with an AKI. And I share your pain because my wife is an OBGYN, and I know what they have to go into. We're kind of running out of the time, but I'll still want to put in one line there with Ravi's work on the biomarkers for the preeclampsia, which is kind of have a very good area under the curve about the VEGF and FLT and others. What's your experience, Sylvie, on that?
So I know they have done great work, but there was a recent study, not a recent study, it was published 4 years back in NEJM, where they looked at SFLT1 and its utility, the ratio, and it actually does not have a good positive predictive value. It just has a very high negative predictive value. I think the ratio is 38. So if you have a high ratio, it just tells you that you will not get preeclampsia within 7 days. So it's really not FDA approved here. We don't do SFLT levels for preeclampsia because whatever research has been done does show that the utility is very low. So it's still a clinical diagnosis, not a clinical diagnosis, and obviously the treatment is delivery, and that's the treatment for preeclampsia. Yeah. So I haven't been using these biomarkers.
Same here. So with that, I'll end the Q&A until otherwise Vinant has anything to add on. But before I end, I want to congratulate you, Sylvie. Very nice supplement of ACKD, and it's very beautifully done, very long awaited, and it will go to OBGYN world, internal medicine. So thank you for the strong work. I'm doing the ACKD supplement. I can understand your hard work. With that, again, I want to thank all the speakers, the panelists, and my special thanks to Vinant for inviting me to this excellent meeting. And you should take a full credit, Vinant, for such a nice layout and such a nice speakers. And thanks to Sir Gangaram for giving me an opportunity. And I will say thank you to everybody and stay safe. Hopefully we'll grow out of this pandemic era. We never want to live in this pandemic era. We just want to wish all of you from our side, stay safe. And maybe next year or so we'll meet, not virtually, but in person, and just want to live and come back to a normal life. Thank you again.
Thank you, Rupesh. And thank you, Vinant, for having me.
Thank you very
Hopefully I'll
much.
see you sometime soon. You know, we live in Noida. We just got to know. So my family is in Noida. So I'm like, hopefully we should meet soon.
Yes.
Thank you, Dr. Bhargava. Thanks a lot.
Yeah.
Look forward to it. Yeah.
Thank you, faculty, organizing team, and delegates for the fruitful day. Now, I would request Professor A.K. Balla, organizing chairman, to kindly conclude the proceeding of the update.
Thank you. At the outset, I would like to thank all the speakers and chairpersons, as already briefly, nicely summarized by Dr. Rupesh Raina, that it was an excellent meeting with excellent thoughts and very informative and in a very concise manner. And it was good that we didn't have very long session today. And tomorrow we are going to start at 8:30 a.m. and we'll finish by pre-lunch, that is around 1 p.m. And we're looking forward, you enjoy your dinner, and in US you enjoy your mornings, and tomorrow we'll have session at 8:30 a.m. I will write Dr. Vinant Bhargav just to give his concluding remarks for today's sessions.
Yes, before I conclude for today's session, I would like to individually thank all the faculty members here, the chairpersons and the speakers, especially the international speakers who have taken out their very precious time. They're in different time zones, as have been told to us. It was very difficult to get them onto a live presentation. We had very good academic discussion today, starting with Dr. Edwin Fernando, who gave us different definitions of AKI and the fallacies of the different definitions of AKI, followed by Dr. Patrick Murray, who told us about the past, present, and the future of AKI, and with special emphasis on the role of biomarkers, as well as initiation of renal replacement therapy, whether it should be early or late. Following that was Dr. Vivekanand Jha, who in an immaculate presentation gave us different viewpoints of the tropical AKI in different countries which are in the tropics. And it was it was very nice to listen to this topic because one of the cases that he presented over there was shared by us when I was with him for a few months. And this was the case of renal mucormycosis in a patient who presented with AKI, and finally we had to do a bilateral nephrectomy. And Dr. Nupurupal gave us a very, very deep insight into the cardiorenal syndrome, which we understand as just a classification. And her points about the role of chloride was absolutely mind-boggling. We have never come across this concept before, and we've never been substantiated on this concept before. So that was a good revelation for, and I think it was a revelation for anybody who heard it. Following this was Dr. Jayakala, who took out a precious time and elucidated the mechanisms of different chemotherapy agents. And she was kind enough to give us information on how to prevent AKI from the chemotherapeutic agents. Dr. Rimda Vanchu, unfortunately, was on vacation, so she had to send a pre-recorded lecture. And I would apologize from the technical team for the technical glitches in the beginning of the lecture. But the lecture was outstanding with giving us insight about how immunotherapy, especially the checkpoint inhibitors, how can they affect the native kidneys as well as whether we can use them in transplanted kidneys or not. And she brought out different treatment modalities for patients who get affected by checkpoint inhibitors, especially steroids, MMF, rituximab, infliximab, though the data was not very convincing. And then we had Dr. Narayan Prasad talking to us about AKI in the elderly and different mechanisms by which the AKI is more predisposed to the elderly. Dr. Siddharth Sethi was very elaborate in his presentation about the pediatric AKI, and he mentioned very clearly in the beginning that it was an independent marker and independent predictor of mortality. And his elucidation about the machines such as Aquadex and the Carpe Diem, and Dr. Rupesh Raina also putting in and chipping in a few words has, I think, been a very good discussion for this session. And to end it all, it was Dr. Sylvie Shah, whose expertise in the field of AKI and pregnancy took us through different avenues of this disease. And finally, she has clarified concepts regarding the biomarker pregnancy-related AKI. It was heartening to listen to all of these faculties and all these dignitaries. And now I would ask Dr. A.K. Bhala to invite you for the session for tomorrow once again.
And another, I want to highlight a lot of excitement and heat has been generated for biomarkers. And tomorrow we are going to have a very heated debate on biomarkers between two doyens of nephrology from India, Dr. K.C. Prakash and Dr. Manish Rathi. So both are experts in their field, and this will be a very, very important, exciting session for tomorrow. So please join tomorrow at 8:30 a.m. Looking forward to you. Thank you.